Northwest Lincoln and Northern Lancaster County.
Good morning, Senator Jen Day, represent Legislative District 49 in Sarpy County.
Senator Michaela Cavanaugh, District 6, West Central Omaha, Douglas County.
Murph Reapy, District 12, which is Southwest Omaha, and the good folks of Ralston.
Also assisting the committee is our research analyst, Bryson Bartels, our committee clerk, Christina Campbell, and our committee pages for today are Sophia and Ken. A few notes about our policy and procedures for this morning. Please turn off or silence your cell phones. We'll be hearing two bills, and we'll be taking them in the order listed on the agenda outside the room. On each of the tables near the doors to the hearing room, you will find green testifier sheets. If you're planning to testify today, please fill one out and hand it to Christina when you come up to testify. This will help us keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. Also note, if you are not testifying but have an online position comment to submit, the legislature's policy is that all comments for the record must be received by the committee by noon the day prior to the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask if you do have any handouts that you please bring 10 copies and give them to the page. We will use a light system for testifying. Each testifier will have 5 minutes to testify. When you begin, the light will turn green. When the light turns yellow, that means you have 1 minute left. When the light turns red, it is time to end your testimony, and we will ask that you wrap up your final thoughts. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last name. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from supporters of the bill, then from those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. On a side note, the reading of testimony that is not your own is not allowed unless previously approved, and we do have a strict no-prop policy in this committee. So with that, we will begin today's hearing with LB 611 and welcome Senator Reapy.
Thank you, Chairman Hanson, and good morning, members of the Health and Human Services Committee. My name is Merv Reapy. It's M-E-R-V, Reapy, R-I-E-P-E, and I represent the 12th District, which consists of Southwest Omaha and the good folks of Ralston. LB 611 saves patients money and has no fiscal note. That's my summary comment. When performing eye surgery, such as cataract surgery, ophthalmologists may use only 1 or 2 eye drops from a medical container. There are often a number of drops still remaining. Because regulations governing the ability to dispense the remaining portion of stock item medications for post-discharge use may be unclear or appear overly burdensome, many facilities do not allow the ophthalmologist to give that container to the patient to take home. The ophthalmologist instead must write a prescription for the patient, and the rest of the medication is tossed. 6B 11, Legislative Bill 611 would resolve this issue. It tells the surgeon they may give the patient the unused portion of medication, ointments, eye drops, and topical creams, and the patient may take it home. Legislative Bill 611 would apply to topical stock item medications, unlabeled ointments or drops that a hospital operating room, emergency room, or ambulatory surgical treatment center staff has on standby or is retrieved from a dispensing system for a specified patient for use during a procedure or visit. We often hear many individuals who come before this committee voice their concerns about the price of medications. Right now, even if a patient has not used an entire container of medication while in a medical facility, the patient may not leave with the unused portion after discharge, even when the patient was charged the full amount and still needs the medication. Patients may need to purchase duplicate medications for post-discharge use, increasing patient costs and creating medical waste. Each year in the United States, up to 3.8 million cataract surgeries are performed. Unlabeled topical ointment cost about $25 a tube, and topical drops cost about $56 a bottle. Both of these medications are often used in cataract surgeries. Americans could save $95 million on topical ointments and $212.8 million on topical antibiotic drugs. This is just two examples. LB 611 would make it so Nebraska patients don't have to shoulder the additional burden of going to the pharmacy after surgery to fill a prescription. LB 611 will better ensure medication compliance and relieve patients of the financial burden of having to make the difficult decision of choosing medication or other daily essentials. You also received a handout, committee members, of Amendment 310, which was shared with you, and it expands the language beyond hospitals to include ambulatory surgery centers and healthcare practitioner facilities, given the fact that the majority of cases do not require hospitalizations. Thank you for your time and attention. I would be happy to take questions. With that, I conclude.
Thank you for that opening. Are there any questions from the committee? Senator Ballard.
I'll ask a question. Thank you, Chairman. Thank you for being here, Senator Repe. This seems like common sense. Can you give some reasons why this would be permitted this year, or why this was made law in the past?
Well, I think it was eligible, it was just unclear. And so rather than take the chance, the ophthalmologist would go ahead and say, rather than run the risk, we're just gonna dispose of those and we'll give you a new one, which is the safest.
Yeah.
From a legal standpoint, but it's not, in my opinion, as you said, common sense, doesn't make any, and it's a burden to people who don't. Medications or pharmaceutical items are expensive, and a lot of people have a long way to go to the pharmacy. It doesn't make any sense to me.
Any other questions? All right, seeing none. Thank you. We'll see you at the close.
Thank you.
All right, we'll take our first testifier in support of LB 611.
Good morning, Chairman Hansen and members of the Health and Human Services Committee. My name is Dr. Patty Terp, P-A-T-T-Y-T-E-R-P. I am a board-certified eye physician and surgeon practicing with Midwest Eye Care in Fremont. I am grateful to have the opportunity in front of this committee to support LB 611, and the Nebraska Academy of Eye Physicians and Surgeons would specifically like to thank Senator Repe for sponsoring this proposal, and he did such a great job introducing. He really has kind of summarized a lot of what I'll be about to say. In general, the healthcare sector generates approximately 9% of total greenhouse gas emissions in the United States and is the second largest source of landfill trash. Prescription drugs account for approximately 10% of healthcare costs in the United States. Operating rooms contribute up to 30% of a hospital's waste. Surgical drug waste significantly increases the cost and carbon footprint of eye surgery. Cataract surgery is one of the most common surgical procedures in medicine, with a large projected increase in global volume. This gives us ophthalmologists a unique opportunity and imperative to prioritize the financial and environmental sustainability of quality eye care delivery. Aside from cost and environmental considerations, needless waste also increases the potential for and impact of periodic drug shortages, which unfortunately have become increasingly common. LB 611 proposes that when a topical medication is administered to a patient at a healthcare facility, that any unused portion of the medication shall be offered to the patient upon discharge when it is required for continuing treatment. This would include topical antibiotic, anti-inflammatory, dilation, or glaucoma drops and ointments. This bill would apply to topical stock item medications. Topical stock item medications are unlabeled ointments or eye drops that a hospital operating room, ambulatory surgical center, or facility staff has on standby or is retrieved from a dispensing system for a specific patient for use during a procedure or visit. When performing eye surgery, eye surgeons may only use 1 or 2 drops from a medicine container. There are often many drops still left in that container. Because the regulations governing the ability to dispense the remaining portion of stock item medications for post-discharge use can be unclear or appear overly burdensome, many facilities do not allow the ophthalmologist to give that container to the patient to take home with them. The ophthalmologist instead must write a new prescription for the patient, and the rest of the unused medication is thrown away. This piece of legislation would resolve that issue. It tells the surgeon that they shall offer to give that patient that unused portion of medication. If a medication needs to be continued after discharge from the hospital, emergency room, or surgery center, it is wasteful to throw away the newly opened multi-use bottle and instead require the patient to purchase the same medication from the outpatient pharmacy. Furthermore, this bill would eliminate the burden on the patient of going to the pharmacy after surgery to fill a prescription. This bill will better ensure medication compliance, relieve patients of the financial burden of having to choose between medications and essential items. Estimates are, as Senator Reapy mentioned, Americans could be saving $95 million on topical ointments, $212.8 million on topical antibiotic drops if this legislation was passed in every state. Please vote yes on LB 611. This is an important step in promoting medical waste reduction and reducing healthcare costs. And Senator Ballard, to answer your question, also a lot of facilities won't let us give the patient the medicine. We try, but the number of times I've had inpatients on a drop and then I have to write a new drop for them to get the same medicine. I'm like, there's so much left. But a lot of this, it's been, and so far in the current statute, it says facilities can, but we want this language to be stronger because most facilities won't let us. So by changing the language and specifying more clearly that the patient shall be offered the medicine, we really want to eliminate that burden where most facilities to this point have not allowed us to, despite us kind of outcrying for years. So we want this to just happen and be commonplace.
Very good. Any other questions from the committee? Cindy, thank you so much for
Yeah,
coming today.
thanks for the time.
Next proponent. Any opponents? Anybody who would like to come and speak in a neutral capacity? We did have one position comment from the Nebraska Medical Association as a proponent. Senator Reapy, would you like to close? Senator Reapy waives his closing, so that would end our hearing on LB 611. And we will open up our hearing on LB 810, Senator Merman.
Good morning, Vice Chair Walls and members of the Health and Human Services Committee. My name is Dave Merman. I'm from Glenville in District 38. District 38 is 8 counties along the southern border in the middle part of the state. I'm here today to introduce LB 810, which would adopt the Medical Ethics and Diversity Act. LB 810 seeks to protect the tradition and professional calling for healthcare workers and providers. It would protect their fundamental beliefs, their conscience, and the integrity of the care they provide in their medical practice. I first became aware of the attacks on conscience protections through my son-in-law, Grant Hewitt. Grant is Southeast Regional Director of the Christian Medical and Dental Association. From him, I learned that 23% of doctors, nurses, and other medical providers have experienced discrimination in the workplace due to their moral and religious beliefs. 36% experience discrimination or pressure from their medical school faculty because of their ethical beliefs. And 20% decided not to pursue a particular medical specialty because of hostility towards their beliefs in that area of practice. The same survey conducted by Christian Medical and Dental Association found that 9 out of 10 doctors, nurses, and other medical providers would stop practicing medicine rather than violate their ethical, moral, or religious beliefs. Section 4 is the main component of the bill. Among other things, it provides that a medical practitioner, healthcare institution, or healthcare payer has the right not to participate in or pay for any healthcare service which violates such persons or entities' conscience, and it prohibits any discrimination against such persons or entities where they assert a conscious concern. This section makes clear that the exercise of conscience is limited to conscience-based objections to a particular healthcare service. The legislation does not waive or modify any duty that an individual or entity may have to provide other medical services that do not violate such persons or entities' conscience. To be clear then, the Med Act is procedure-specific, not patient-specific. My office and I have been working with the Attorney General, DHHS, and PRO on an amendment to sections 5 and 6 that would work within the state's obligation to protect patients from mistreatment or maltreatment, and will strike the 14-day requirement on providing notice of a complaint against a medical provider. State statute elsewhere prohibits the state from providing the medical provider with such a complaint. At the end of the day, 810 is doing something very simple. It is protecting the diversity of belief within the medical field. Whether you're a Democrat or Republican, liberal or progressive, or social conservative, atheist or a person of faith, whether you are Jewish, Muslim, Christian, or Hindu, this legislation recognizes that those serving in the healthcare are moral agents. They are individual and personal human beings with consciences that deserve protection. LB 810 manages to appropriately balance the conscience of healthcare practitioners and entities while remaining committed to providing ongoing, compassionate, and professional care to patients. Vice Chair Walls and committee members, thank you for your consideration of 810. I'm happy to take any questions you may have, but there are also several behind me, healthcare practitioners and policy experts that can also help address any questions.
Thank you, Senator Merman. And Senator Hansen, because we have so many testifiers and we want to be able to hear everybody, Senator Hansen, we're going to do 3-minute testimony on LB 810. Let's see if we have any questions before. Any questions from the committee? I don't see any. Thank you, Senator Merman. So we'll go with our first proponent. Good morning.
Good morning. Hi. Okay, I think I'll get started here.
Sure.
Okay. Members of the HHS committee, thank you for your service to Nebraska first. My name is David J. Hilger, MD, DAVID, J, HILGER, and I am here to testify in favor of LB 18. I am a diagnostic radiologist and have practiced for over 40 years, mostly at the 2 of the larger hospital systems in Lincoln and Omaha. I am here on behalf of the future of medical students, young physicians, and medical providers, and to protect the doctor-patient relationship, which depends on conscience. As medical providers, our conscience is formed by our ethics values, as well as our medical knowledge and experience. It is not possible to separate these components of conscience. I would like to share some data. In 2016, a review of over 1,000 studies showed that less than 50% had good, that is moderate or very good evidence supporting specific medical interventions. So less than 50%. Over 50% did not have those criteria. A repeat study in 2020 showed no significant change. The references are attached to my testimony. Good science takes time, often decades to resolve complex issues. There is often uncertainty in medical science, which is the reason that good clinicians differ on complex ethical issues. Conscience is essential when science becomes unclear. Over 10 years ago, the Nebraska Medical Association passed a resolution supporting conscience protection, and I testified on behalf of the NMA supporting a bill based on that resolution. While working on that project, I spoke to a well-known past president of the NMA. We differed on our values and belief systems. However, he said to me that he supported this resolution since he knew that by defending another's conscience, he defended his own. The issues and outside forces have increased over these 10 plus years. The medical profession and the rights of conscience are being eroded by rules and regulations by large government and corporations, often influenced by ideological and financial reasons. By far the greatest concern I hear is from medical students, whether they will be able to practice medicine according to their ethics and beliefs. It is a fear that they might have to compromise or face economic and personal hardship. This fear is real and is a form of discrimination. This will likely discourage many good students from entering the profession when there is an increasing demand. By the way, there are several students that were interested in testifying today, but were fearful of the consequences. Patients need these future providers since they reflect the values of a large number of patients and offer diversity that is needed in medicine. Patients seek physicians not only based on their competence, but also based on their ethics and values. In summary, conscience protection protects the integrity and future of our profession, allows for a diverse opinion and open scientific dialogue, and protects the rights of patients to choose a physician who reflects their own values. Thank you for allowing me to testify, and I'll take any questions.
All right, thank you for that. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman Hanson. I believe you testified maybe 10 years ago. And at that time, the Nebraska Medical Association, I believe, embraced the idea of protecting, respecting the right for confidentiality or conflict of interest or conscientious objection. What has changed in that period of time, in your opinion?
So there's a long answer to that and a short answer to that.
You're off the light now, so maybe I'm not encouraging you.
Of course, the culture has changed, and politics has changed, and that's kind of the short answer. Like all the issues of ethics, there's a broad spectrum of what physicians and other healthcare providers, and as Dr. Rosenberg said the other day, I listened to the testimony on ethics. It's not a bell curve. It's a broad curve. And so I think that if anything, what's changed is the increased pressure on the profession from government sources, from industry, outside influences. So I think if anything, there's more of a need for this bill than there was 10 years ago. There has been discussions. I'm on one of the NMA committees, legislative committee, and there is some ongoing discussion to try to come to some agreement on some of the provisions of the bill. And so I'm hopeful that at some point in time we can come to agreement on those things. Thank you.
Second question.
Yes.
Thank you. You're a physician.
Yes.
Yes, you are a specialist, but you also, what does it look like in a clinical setting with a patient in discussing the conscientious objection? I mean, what would that generally look like?
Yeah, and since I am a diagnostic radiologist, I unfortunately I don't have to run into a lot of those issues. I see them and talk to my colleagues about them because I talk in radiology. We kind of see a broad spectrum of what happens in medicine. So my specialty is with subspecialty is women's imaging and women's healthcare. So I talk to a lot of patients about their mammogram results and the consequences of that. So fortunately, I don't run into that. I kind of run into things a little bit peripherally, but I don't directly run into those things. But the main thing with the doctor-patient relationship, I think, is that patients expect you to be honest. And that honesty may include when you have to tell them something that might not be the best for their health. And for me, the science and the ethics aren't separate. My ethics and my supports the science that I believe in and vice versa. So I think some of my colleagues might be able to answer that question a little better for you, Senator.
I very much appreciate you being here. Thank you.
Thank you.
Thank you. Nice chair.
Senator Day.
Thank you, Chairman Hansen, and thank you, Dr. Hilger, for being here today. Can you just give me an example of if this bill were to pass in your practice, a time where you feel it would benefit you?
In my practice, it's hard to give an example. I did run across a situation many years ago or several years ago, where I was being a little bit more conservative on the interpretation of early pregnancy ultrasounds and kind of favoring and we kind of consider that everything in medicine may be hard and is so black and white. I'm a radiologist. I see a lot of shades of gray, but so anyway, I was more conservative than some of my colleagues, and I wanted to give the baby every chance and the mother every chance to having that child. And so I received some criticism on some of my reports. And so the way I dealt with that is I reached out to the medical literature and found some good references where we could have some standardization of how we interpret these studies. And those were subsequently adopted. And so I think in medicine, we have a unique opportunity to reach across and talk to our colleagues and resolve issues like that.
Okay, so the example would be specifically with pregnancy or termination or abortion?
No, I never had that. Well, it was, I indirectly read termination. If there was no fetal viability, then there would be a termination.
Okay, thank you, appreciate that.
You bet, sure.
Any other questions from the committee? Seeing none. Thank you for coming.
Thank you.
Take our next testifier in support of LB 810. Welcome.
Good morning, Senator Hansen, members of the Health and Human Services Committee. My name is Dr. Dale Michaels, DALEMICHELS. I'm a retired family physician and the Nebraska representative of the American Academy of Medical Ethics. I'm here to testify in support of LB 810 for health professionals involved in various fields throughout the state of Nebraska. Health professionals should have the opportunity to provide health care based on their deeply held belief in the correctness of the care they provide and not the requirement that if the activity is legal, they must do it. Attached as well as a statement on the healthcare right of conscience from the American Academy of Medical Ethics. Imagine, if you will, the following scenario. An individual wants some electrical work done on his home. The electrician looks at the job and is both capable of doing the work and it's legal to do so. But the electrician is unwilling to do it because of the high risk of burning the house down. The electrician not only believes it would be unprofessional to take on the job, but feels morally convicted against taking on the job because of the high risk of harm. While the electrician declines the work, he provides a list of other electricians in the areas. The homeowner contacts several electricians until he finds one who does the job. Unfortunately, the house burns down. My question is, does the first electrician have any complicity in the house burning down? I don't believe so. What if the first electrician had recommended a specific electrician that would do what the homeowner wanted done and the house burned down? The first electrician could be considered morally complicit in the resulting house fire, even though he recommended it against it based on experience and a sincere belief that a fire would result since he recommended the second electrician. This plausible scenario sheds light on an issue that has been raised in the past about LB 810. Some have objected to this bill because it lacks a direct referral component where a healthcare practitioner is unable, due to conscience reasons, to provide a particular healthcare service. But requiring a healthcare practitioner to directly refer for a service they themselves wouldn't provide raises serious moral issues, as demonstrated in the example I just provided. This is a reason that a directed referral should not be required as a part of LB 810, although referral and transfer of records is appropriate. There are several other issues that have been objected to, but are not real life issues. For example, my 44 years of experience has shown time and time again, patients who wanted me to provide a service I was unwilling to do so quickly found someone else who would provide that service. They didn't need me to help them figure out where else to find somebody who could provide them the healthcare service they wanted. This is a good bill. It will protect any healthcare practitioner who has a conscience, which means it will protect every healthcare practitioner. So I'm asking you to advance LB 810 to the floor of the legislature. Thank you for your time. Be happy to answer questions.
All right, thank you for coming. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hansen. And thank you, Doctor, for being here today. I appreciate your example of the electrician and the house burning down, but could you, so you mentioned, I'm going to ask you the same question I asked the previous testifier.
Sure.
Can you give me an example of a time in your practice that what were the circumstances around the situation where you felt you were morally objected to providing a service? What was?
There were a certain number of services. In fact, during my 44 years, some things that initially I was willing to do, but as I studied more, learned more, I chose not to be able to do some of those things. And in those cases, if patients came to me and said, I would like you to do this or provide this service, and I felt I couldn't morally do that, I would tell them I couldn't morally do it. I'm sorry. If they wanted to find someone else, I would be happy to send whatever records I did, or in some cases, I didn't do an exam. I just simply didn't charge them, gave them the information, explained my position, and they were out the door able to, usually, as far as I know, in all cases, they found somebody else.
Okay, so but specifically, can
Well,
you give me an example of a service that you wouldn't be?
One
willing
of the
to
things
provide?
that originally I was willing, and this is just one example, but originally I was willing to use IUDs
Okay.
for female patients who didn't want to get pregnant. I chose, after some time and understanding of how the IUD worked, to no longer perform that service. So I didn't do it. I explained to patients why I wouldn't do it, what my concerns were, and then went from there. If I did their exam, then I would send copies of the records. In some cases, I didn't even do the exam. I just didn't charge them, explained it to them, and moved on.
Okay, thank you.
Senator Beller.
Thank you, Chair Hansen. I'm going to give you an opportunity to respond to some of the correspondence that at least I've received, that Nebraska has a workforce shortage, especially in the medical field, and that this bill is going to limit access to care. Can you respond to that a little bit?
From my personal experience, no, I don't think it's going to limit access to care. It's going to allow certain healthcare professionals to say, no, we can't do this, but it doesn't mean that they can't find the care in other places or in other ways. I practiced, in addition to being here in Lincoln for 44 years, I practiced in a small community part-time for 35 years. And we had patients who would come in to see us. We would take care of their problem, and then they would drive to Lincoln for their prescription or for something else. So I think access is somewhat of a smokescreen. I really don't think that it is involved. I found patients who could often would do things, find ways to do things without necessarily needing something from me if I felt I couldn't do the service. So I don't believe access to care is limited.
Okay, and you don't see this as a problem in rural Nebraska?
No, I really don't. I mean, many of my friends, colleagues, family members in rural Nebraska have to drive long distances just to buy groceries, for instance. They're used to that. And I have found in my experience that the patients learn pretty quickly that if doc such and such won't do this, I won't go there. I'll go somewhere else. And they may go the other direction or a different direction. So I don't think that's a problem realistically.
Thank you for being here.
Any other questions? Senator Day.
Thank you. Sorry, I have one more question for you.
Sure.
Related to the example that you gave, you talked about IUDs and pregnancy, so that would only apply to women.
Mhm.
Do you feel like it's discriminating against women in terms of not providing them medical care? We're not talking about buying groceries or a house repair. We're talking about a human being that needs
Sure.
medical care. Do you feel like that's
I don't
discriminating
think
against the patient?
we did not provide them the medical care. We said that we could not, or I could not, in my case, provide that particular service. But I gave them all of the options in the community or in the area or whatever you may say to provide the service. We didn't say that this is an illegal service. This is a service that you can't get. We didn't, I've seen in some other states where a pharmacist, for instance, withheld the prescription and refused to give the prescription back to a patient. I think that's inappropriate. I don't think that's a part of this bill at all. It's just simply, no, we can't do that, but there are other options.
Thank you.
Any other questions? All right, seeing none. Thank you.
Okay,
Fine.
thank you.
We'll take our next testifier in support of LB 810. Welcome.
Mr. Chair, members of the committee, my name is Stephanie Nichols, STEPHANIE-NICHOLS, and I serve as legal counsel for Alliance Defending Freedom. I work throughout the country on legal issues affecting medical rights of conscience for doctors and nurses and others in the medical profession. We stand at a precipice in our country regarding the culture of medicine. The demands being placed on doctors, nurses, and others in the medical profession are changing. Patients and institutions now often treat physicians like vending machines, demanding that they perform procedures or give out drugs that might actually harm and cause the physician to violate their Hippocratic oath to do no harm. In some cases, patients even sue when they are turned down. LB 810 will help reverse this dangerous trend by accomplishing three main things: protecting the right of conscience of doctors and nurses to decline to provide specific medical procedures that violate their conscience, protecting doctors and nurses from being suddenly forced or coerced to participate in an abortion through requiring written opt-in first. And number three, protecting the First Amendment rights of doctors and nurses, except in situations where harm to their patients might result. There are some things to note about how this bill accomplishes these goals in a balanced and legally appropriate manner. First, I would like you to recognize that the duty to provide emergency care is recognized on line 3, page 7 of the bill. So we are talking about non-emergency situations. Also, I would like you to pay attention to lines 22 and 23 on page 5 that state, the exercise of the right of conscience is limited to conscience-based objections to a particular healthcare service. You can't have a conscience objection to serving a person. You can only have a conscience objection to a particular service. And we also have a long-standing track record of how these laws work in the real world. They've been passed in 5 other states, most notably Illinois and Mississippi, that have had their conscience law since 1977 and 2004. And the medical community and patients have been able to prosper in those states. The conscience bills work by drawing a line in the sand that conscience needs to be respected, and then institutions, patients, and doctors are able to work together to this end. What this bill does is codifies what is actually best practice, what's good for the patient, what's good for institutions, and what's good for doctors, and encourages them to work together. It also protects the free speech rights of doctors to discuss methods of treatment that may pose a risk to patient health. This is important because good science equals good medicine. And good science requires freedom of speech and freedom to debate. The final thing I would like to leave you with is, who wants a doctor without a conscience? And now I'm free to take any questions the committee may have for me.
Right. Thank you for coming to testify. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hanson. I'm going to keep asking the same question that I've been asking of every testifier. Can you give me an example of a service for which you have heard doctors would not be willing to provide, like a specific type of service?
Yes, absolutely. So I have had conversations with many physicians throughout the country. They often are being compelled or coerced into feeling like they have to participate in surgeries that would sterilize minors or remove healthy body parts from minors. Physician-assisted suicide is a major pressure on doctors. And technology is changing very quickly. So it's important, you know, we get questions about this bill that, okay, why does it not just list out specific services? We couldn't have known as a country 5 years ago what today's conscience objections would be and what physicians would be asked to do today 5 years ago. So if you pass this bill with a specific list of services, then it's obsolete very soon as technology rapidly changes. I'll give you a good example. Gene editing is now becoming prevalent in assistive reproductive technology. So you could have someone who works in that field being asked to do gene editing procedures. And that may be against the conscience of someone who is a fertility doctor. And that's on the forefront of changing technology.
Okay,
Thank you for that question.
thank you.
Senator Ballard.
Thank you, Chair Hansen. Thank you for being here, Ms. Nichols. I like that you mentioned the real world. How does this work in the real world from a legal perspective? Like what steps does a physician have to go through?
Okay, so when the patient presents to the physician and the physician has a conscience objection under this bill, they have to, if they are employed by an institution, they have to let the institution know that, okay, this patient has presented to me and I have turned them down, due to reasons of conscience. So within a healthcare facility, there will often be other practitioners who can morally provide that service to the patient who's requesting it. But the main thing to remember as you go through the bill is you will see that there are a few references that the practitioner must continue to serve the patient with all other appropriate healthcare and services. And this is how this bill actually goes beyond the AMA Code of Ethics, which actually lets a physician let go of a patient who they can't serve with a particular healthcare service. This bill protects the patient by saying, hey, you get to keep your doctor. They have to continue serving you with all other appropriate healthcare services that do not violate your conscience. So, for example, nobody loses their primary care physician just because that patient has asked the physician for a service that they can't provide.
And one more question, if I may.
Yep.
And then you said, what's 2 states do you already have a medical conscience?
There are 5.
5? Okay.
3 are more recent. So Arkansas and Ohio passed these laws in 2021, and South Carolina passed a law last year. But the 2 states that have a long-standing track record that lets you have confidence in how this works in the real world are Illinois and Mississippi. Illinois, blue state, has had the law since 1977 without any type of major issues. Same way with Mississippi. There have only been a handful of cases brought under the conscience laws, because what the conscience laws do is draw that important principle out, and they encourage the institutions and the employees to work together to make sure patient needs are met, but still practitioners' consciences are respected. That's actually very important for access to care, because 9 out of 10 practitioners who are people of faith would rather quit practicing medicine than be forced to violate their conscience.
Thank you.
Any other questions? Senator Reapy.
Thank you. I have friends in East Texas. May I guess and speculate you're from Texas?
Close. I am from the neighboring state of Arkansas.
Oh, okay. Okay, kissing cousins. Okay. We talked a lot of, and I think where I was going to go with that is if you were from Texas, you didn't list Texas as one of the states that has this law. Texas is particularly conservative.
Texas they have a filed bill this year, and
Oh, do they?
yes,
Okay,
yes.
that was my question. Why would they not be included in that list?
Right.
Because they're pretty active right now with a
Right.
number of pieces of legislation.
Definitely. There's a doctor in Texas who is a strong legislator who is running the bill in Texas this year. So
Okay.
they may likely have the bill this year. It's also a legislative priority for Governor DeSantis in Florida.
Okay.
There have been more bills filed on this year than any other legislative year. I think we're up to around 11 states that have filed legislation on this year, because it's such an upcoming issue and something that's really pressing upon doctors and nurses at our time.
Well, tell Governor Huckabee hello for us.
I'll send your regards.
Okay, thank you. Thank you for being here.
Thank you.
Any other questions? I have a few questions. Just appreciate your legal analysis with this.
Thank you.
You kind of touched on this a little bit, other states that have done this. And I think you might have answered it, but has there been any litigation or any lawsuits that from the states that have passed this?
There have been only a handful of cases filed. They have been in things like the abortion context, Catholic healthcare practitioners who didn't want to be forced to provide contraception when others within the healthcare facility who were employees could easily provide that service instead. And, honestly, it hasn't come up in the hospital context that I'm aware of, but there have been a few cases involving clinics. And one thing that's important that I did want to call attention to, some people assert that the practice of medicine can't function because the bill prohibits transfer of job duties from a practitioner to other job duties. And that's actually not correct. If you will look at the definition of discrimination in the bill, the way the medical community is still able to function from a business perspective is that discriminatory adverse transfers are prohibited. For example, if you take that nurse, it's not that you can't ask her to take on other job duties instead, but you can't take a day shift nurse and now punish her with switching her to night shift just because she refused to participate in an abortion or other service. And there's also good case law. There is a case in Illinois that articulates very well that conscience must be interpreted from a reasonable business perspective as the legislature would have intended. So for example, in the case of Rojas versus Martell, an employee can't expect to do no job duties under conscience and then get a paycheck. That was not the issue in the case. Abortion and contraception was the issue in the case, but the court went further and articulated that transfer of this employee was appropriate to other job duties. That's actually what the employee wanted, was transfer to other job duties. But at the same time, that the medical community was not to be hamstrung in that way. Only discriminatory, retaliatory transfers that put someone in an adverse position were prohibited.
Okay, I think that's kind of another part I was wondering about.
Yes.
Is we're trying to protect the doctor, but I also want to make sure that the business is protected as well.
Right.
And so like if it's a private clinic and they start maybe moving more towards doing, use an example, like doing more abortions, right? And you have a doctor who's already been, employed there, and he's like, it's against my conscience. Is the business able then to fire him because now he's primarily not doing his duties according to the clinic?
And no, the business would not be able to fire him in that context. What the business would have is on the front end, for example, Planned Parenthood doesn't have to hire a pro-life employee under principles of freedom of association. They get to ask on the front end, can you do these job duties? But let's say, for example, you have a nurse that's been employed 30 years for a healthcare institution, and suddenly she is asked to participate in an abortion or have her job threatened. That's really neither right nor fair. But on the front end, it's a different story. And that's why this bill does not cover employment on the front end, and why it's important to recognize freedom of association on the front end. And that's a good way to draw that line of balance.
Okay. And more for clarity's sake, so is this allowing doctors to do whatever they want? Or is it more about like not doing certain procedures or recommendations?
Great question. Thank you, Mr. Chair, for that question. Conscience is always the right to decline to participate in something. And that's why the way conscientious objection has always been interpreted in our case law in the country. But it's also the way this bill has been drafted. It's the right to decline to participate in a specific procedure. It's not the right to do any procedure or prescribe any drug you wish.
So sorry for asking more questions.
Sure.
So where's the line at then? Where's the line that where a business can then say, okay, doctor, you are not doing your primary duties of the clinic because we're doing more cloning now of whatever, we're going to clone animals now. And the doctor's like, well, I don't like cloning, it's against my religion. They cannot let him go because now he's not primarily doing his duties according to what the business wants. Can they still not let him go, or does he just stay there and be employed and not do anything? Or
I think the responsibilities of the institution in that case would be to find other job duties for him to do that were not discriminatory. So it's not retaliatory or punishment, but the way it has worked in other states is conversations are had, and maybe it is the responsibility of the business to work with their medical practitioners. On the front end, it's easy. It's okay. Can you provide these services that we provide? When things change dramatically on the back end, it can be a little bit harder. But it is the responsibility of the institution to work with their doctors and nurses to see what they can provide.
That was kind of a outside the ballpark example.
Sure, but when
I'm assuming
techno-
it's not going to happen that often, but it's still when I work through the nuts and bolts of this.
Right. And when technology is changing at a rapid pace, that may be a question for the future.
And one more question, if I can. How would this pertain to vaccines? So I know some people, they believe there's stem cells in vaccines, and so, or aborted fetal cells in vaccines, or it's against their conscience to provide an mRNA vaccine because of whatever reasons, right? Again, kind of an outside question, but it could occur within the next 5 years, like you said. How would that work?
That's a great question. Thank you, Mr. Chair. So this would not protect employees of healthcare institutions from having to take a vaccine themselves. It would protect in the situation, for example, I'll give you a situation out of Virginia. A pharmacist who administered COVID vaccines to adults was fired and lost her job because she did not feel confident in the science and research safety studies in giving it to young children. So she lost her job as a pharmacist because although she would give the vaccine to adults, she would not give it to young children. So that would protect that pharmacist if that was grounded in a conscience belief and not just a scientific belief.
Okay. And the same for like a medical doctor in a hospital.
Absolutely.
Okay.
Yes.
That's-
Now, an important thing to note is vaccines are easily accessible. So if you have one doctor, I've actually never met a doctor who was anti-vaccine wholly. There might be some who weren't confident about this or that new vaccine on the market, but I've never met an anti-vaccine doctor yet in all my travels and conversations. So, it's easy to access a vaccine from another provider. So that shouldn't raise any major red flags on the vaccine issue.
Okay. Thank you for that. Appreciate that.
Thank you.
Senator Day.
Sorry, I just thought of one more question related to what Senator Hansen was talking about in terms of the institution. So just to clarify one more thing, it sounds like if a doctor refuses to provide services based on conscientious objection, that institution cannot, they're protected under this bill from being fired by the institution.
They are.
Okay, so I guess the thing that I struggle with that, in what other industry or terms of employment can an employee refuse to provide the services that are required of employment and still not be fired?
What's important to recognize in this situation is there's a major issue of shortages of doctors and nurses. And like I mentioned earlier, 9 out of 10 who are people of faith would rather leave the practice than be forced to violate their conscience. So this is the type of circumstance that if you don't legally protect conscience, it's actually exacerbating the physician and nurse shortages in this country.
But because of the shortage, wouldn't we need more medical professionals to be willing to provide services instead of having medical professionals who are unwilling to provide services? Because if they're not willing to provide the services that they are employed to do, then effectively they're not useful in terms of access to medical care.
But they are useful for all the other services that they will provide to their patients besides that 1 or 2 specific healthcare services that might violate their conscience. So for example, a doctor might not provide abortion services, but they're bringing babies into the world. They're caring for the elderly. They're making sure kids get antibiotics on time. We need to make sure as a country that we are fully deploying as many licensed doctors and nurses as we can, that we are not closing the door to practice for them, that we are not forcing them to violate their conscience and exacerbating shortages that way.
Okay, thank you.
Thank you for the question.
Any other questions? Senator Reed.
Thank you, Chairman Henson. My question is this: there have been other cases of conscientious objection in terms of baking wedding cakes and flower arrangements. Is there any CPG crossover between this particular medical specific legislation and other precedents set, legal precedents set in those cases?
That's a great question. Honestly, this is my area of focus in employment, so I'm not probably qualified to answer that question on the case law on other fronts.
So you're not into cakes and flowers?
I love cakes and flowers, but I don't have any legal expertise on those
Okay.
issues, but thank you for the question.
Thank you.
Senator Kavanaugh.
Thank you. I'm sorry, I was introducing another bill, so I missed the beginning of your testimony. The name of your organization is Alliance Defending Freedom?
Yes.
And are you here in an official capacity for them? Are you an invited testifier?
I am an invited testifier, and I am appearing in my official capacity to support this legislation.
Okay. I asked because I didn't see you registered as a lobbyist, which is a nice protocol to have, but not necessary, but just.
I am
Wanted
only
to-
here to testify, and I will be leaving the state thereafter.
Yeah,
so it's not
you don't
me
have to leave the
myself.
state. I am not inviting you to leave the state. I'm just kind of saying for the general public that it is a nice process to have our people who are lobbying to register for lobbying, but you are an invited testifier. So thank you for the clarification. You are, well, you just said you're leaving the state, so you might not be the right person to ask about this, but abortion has been discussed since I've been back in the room, and is there an instance where people are being forced to perform abortions in Nebraska where it is against that they are conscientious objectors? Because I am not aware of these instances.
I am not aware of a specific instance involving abortion in Nebraska. I am aware of many issues throughout the country.
Okay.
It would
Because in Nebraska, you can only get an abortion that's not an emergency at an abortion clinic. So I would say that it would probably not be appropriate to seek employment at an abortion clinic.
I would agree with you. If you have a conscience objection to abortion, this bill would not impact the ability of the abortion clinic under constitutional principles of freedom of association to hire who they want to further their goals and objectives.
Right. So then that brings us to most abortions well, not most, all abortions outside of an abortion clinic setting in the state of Nebraska are an emergency. And so this would mean that if you are a medical provider working in a hospital setting and a woman is going to die, you can delay access to care for that patient because you disagree with saving her life.
Well, we do reference emergency medical treatment. So EMTALA, the federal statute, would require that woman be given emergency care to, preserve her life. And we recognize that in this bill. True, this is for non-emergency.
Okay, so this
Situation.
basically doesn't cover abortion in the state of Nebraska then?
Well, so that's another question. So in states like Arkansas, it's easy for on paper it to look like abortions don't happen in hospitals.
They do happen in
What we-
hospitals. In Nebraska, they happen in hospitals to save the life of the mother. And so we're providing abortion care in hospitals as an emergency.
And that's definitely what the letter of the law says. But we have been involved in enough cases as Alliance Defending Freedom to know that abortions also happen in non-emergency situations, even where it's not legally permitted.
Well, then that would be a crime. So that would be a totally different, we don't need this bill to address crimes.
But do you need this bill to address the situation where a nurse is, coerced into participating in an abortion against her will? Does she have any legal?
Not if it's a crime, then no.
She should have civil recourse. And this would provide that civil recourse for her.
Civil recourse against committing a crime.
No, civil recourse if she is forced or coerced, what happens often in situations.
But you literally cannot, there is no hospital in the state of Nebraska that will provide an abortion
Well,
unless it is an emergency. There's not a single hospital in the state of Nebraska. if they thought that we thought that they were performing abortions, they would be in here telling us that they are not performing abortions. They have been very outspoken about the fact that they do not perform abortions in hospital settings in the state of Nebraska. And so I'm just trying to get clarification that this bill actually has nothing to do with abortion, because you can have an abortion in an abortion clinic. You should not seek employment at an abortion clinic.
No, and this would not affect
And you
that.
cannot have an abortion in a hospital setting unless it is a medical necessity. And so you would be denying them emergency care. And if it's not in that setting, then everything's fine.
I agree that this bill would not impact
Okay,
abortions required.
that's what I was
under
trying to
the
get
county.
at.
Yes.
Thank you.
Senator Day.
One more question. I appreciate your willingness to answer all of these questions. So Nebraska is an at-will employment state, meaning you can be fired for any reason or no reason at any time. How would this interact with that?
By protecting conscience, you would find more rights for employees who are in the medical field.
So we would essentially be creating a carve out only for physicians, but not anybody else.
Well, not just physicians, but nurses and others in the medical field. Only those who are directly involved in the provision of an actual healthcare service.
Okay, so
So, for
only for
example-
medical related people, but no one else. So we're an at-will employment state, but those that work in medicine would be protected, but no one working in any other industry would be protected from being.
That is true. This does not have conscience protections for those in other fields. It's only in the medical field. And in many other states that have passed this are at-will employment states as well. Like Arkansas has passed this, it is a carve out, like you recognize. And we had a conversation so this has been in place in Arkansas for 2 years now. The Arkansas Hospital Association director was asked, have there been any issues with the medical conscience law in the state? And she said there have been no issues. So no cases filed in 2 years and no employment problems for hospitals.
Okay.
Thank you.
Any other questions from the committee? All right. Seeing none, thank you for coming.
Thank you for
Appreciate
your
testimony. We'll take our next testifier in support of LB 810. Welcome.
Dear Chairman Hansen and members of the Health and Human Services Committee, my name is Dr. Carolyn Manhart, Carolyn Manhart. Thank you for your service and for your time today. I'm a general internal medicine physician providing primary care for adults for over 22 years. 12 years ago, a 70-year-old man came from 3 hours away to see me as his doctor. He had diabetes and erectile dysfunction, and I began prescribing Viagra to him. Eventually, he shared that he drove to Omaha to see prostitutes, claiming he was helping the girls get through school. After much reflection, I told my patient I would no longer prescribe Viagra to him. He was dismayed and tried to change my mind about once a year, but continued to see me for several more years. 3 years ago, I was prescribing Viagra to another patient. Both he and his wife were my patients. When he told me he was using Viagra to have affairs, I could no longer prescribe it for him, and he was furious. "Don't impose your values on me," he said. He called the office threatening lawsuits. He didn't want to find another doctor because he felt I was the first doctor to listen to him. Fortunately, he never sued. When I forewarned another doctor that this patient had an appointment to see him for Viagra and I explained the situation, this doctor replied, "It's legal, so I don't have a problem with it." State senators, which doctor do you think is acting in this patient's best interest? I know I offer good care, and I cherish my patients, my 1,600 patients. But if I had to prescribe or directly refer for treatments that I believe are harmful or immoral, I would have to leave my practice. I'm also here today because many qualified and compassionate young people are told to suppress their deeply held values to be able to practice medicine today. Through a medical organization I'm involved with, I've had the honor of mentoring several medical students. Last Sunday, 12 of these students were in my home, wrestling with whether they should testify here in support of this bill. The reason the students are not here is the very reason this bill needs to be passed. They are afraid that publicly testifying for physician conscience protection will harm their chances of a competitive residency, future fellowships, and getting the job they work so hard for. In summary, I am not forcing my patients to believe what I believe. I'm not withholding life-saving care. I'm doing what I think is best for my patients, and the types of services that I do not provide comprise a tiny portion of all the care I do provide. Please pass LB 810 and ensure that all physicians can continue to practice in Nebraska without the threat of discrimination, lawsuits, or the loss of employment because they have followed their consciences, while still ensuring patients are cared for. Thank you.
Thank you. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hansen. Thank you, Doctor. I didn't catch your name. Can
Carolyn
you-
Manhart, CarolynManhart.
And you're from here in Nebraska?
From Omaha.
Okay,
Yes.
perfect. Thank you. And then, just like I asked the other testifiers, can you give me an example of a service that you would be morally objected to providing?
Well, the reason I came here today, because I thought my two stories were so impactful, because these are Viagra patients, and we see Viagra patients every single day. And it's not that I don't prescribe Viagra, but there are certain situations in which I think it's wrong. And I hope you can see, even if you don't agree with my decision, where my conscience came into play in these two situations. One in which a gentleman was using the Viagra for prostitution, and the second one in which he was using it to have affairs. So this is a perfect example, I think, something besides abortion, in which a physician would use his or her conscience to say no to a patient.
Okay, thank you.
You're welcome.
Senator Kavanaugh.
Thank you. Thank you, Dr. Manhart. I don't think that this would apply in your situation. This is a moral objection to, if you didn't prescribe Viagra across the board, but applying it disparately, this would not apply to you. I just wanted to make that
This
clear.
bill wouldn't protect me from being
No.
sued?
No.
The way I understood it, and I'm not a lawyer, but that this bill would protect any physician who, for moral reasons or ethical reasons, would deny care of a
Specific
particular.
care, not for specific reasons.
The specific reason is a conscientious objection.
Right, but you cannot deny care to your patients because you don't like or agree with them. This protects you from, if you don't agree with prescribing Viagra to patients, this would protect you. But not prescribing Viagra to patients for reasons that you object with their use of it, it would not protect you.
Senator Kavanaugh, I just want to give an example. Like every day I'm giving Percocet to patients. So I will give Percocet to a patient who's had an ankle fracture, but I won't give Percocet to a patient that has had a back strain. So the type of treatment that I'm giving is specific to the context in which the patient is asking for the treatment.
I understand.
so,
I was just trying to
yeah.
clarify for you that this does not apply to the specific example that you gave. And that's fine. I just wanted to clarify that for the record.
Any other questions from the committee? Okay, seeing none, thanks for your testimony. We'll take the next testifier in support.
Hey, good morning. My name is Paul Esposito, MD, PAULESPOSITO. Good morning, Mr. Chairman and members of the Health and Human Services Committee. I appreciate the opportunity to speak for you in support of this Medical Ethics and Diversity Act. I'm a recently retired and happily pediatric orthopedic surgeon from the University of Nebraska Medical Center, where I'm an emeritus professor of orthopedic surgery and pediatrics. I also work for the Children's Hospital Medical Center, where I last served as surgeon in chief, so I have a lot of experience in administrative activities. I continue to be an active member of state, local, and national medical societies. I am here to testify my personal beliefs and opinions related to this bill and do not represent any of my prior employers or the organizations that I'm a member of. I've been an educator throughout my career to thousands of surgical, medical, resident physician, medical students, nurse practitioners, physician assistants, and nursing students. I've had their ear for many, many years. Over the years, they're more and more expressing concerns and anxiety over how medicine is evolving and if they will be able to practice in a manner they believe is morally and ethically acceptable. Shortly after the passage of Roe, when I was a medical student, before life got even more complex, if a student or physician chose to participate in procedures such as abortion, they could do it and it's perfectly acceptable to decline. The complexity and increasing numbers of such potentially morally conflicting circumstances has increased rapidly in the past decade, especially as both technological and medical and social ethics have changed. This is placing increasing pressure on all students and medical practitioners. Asking anyone to do something unconscionable is itself unconscionable. I've had the opportunity to work with and lead a very diverse group of highly skilled, trained practitioners from a variety of backgrounds. There is an increasing concern amongst them regarding federal and medical mandates. This is having a chilling effect on those presently working in healthcare, on individuals considering entering nursing and allied health careers, as well as the physician's choice of specialty. When these concerns are based on religious beliefs and moral conviction, they must be respected. Quality care will be greatly harmed if individuals are not bound to their patients through mutual agreement and principles of treatment. This potentially could lead to increased morbidity and mortality despite technical medical advances. Individuals who have a medical vocation bring their deeply held beliefs to their practice. Those who are constantly questioning if what is being offered their patient is moral and ethical, in my opinion, are better clinicians. Placing people in what they firmly believe are unethical or immoral positions will drive them away and further contribute to the shortage of healthcare workers in our state and nation. It's my opinion that LB 810 clearly provides the protections practitioners required in an ever more complex medical environment, which is changing constantly without limiting access to care. As the protections of LB 810 are not enacted, in my opinion, there will be a precipitous decrease in the availability of thoughtful, well-trained medical providers to the citizens of our state and region. Thank you, and I'd be glad to answer any questions.
All right, thank you for your testimony. Are there any questions of the committee? Yes, Senator Day.
Thank you, Chairman Hansen, and thank you, Dr. Esposito.
Yes, sir.
I'm going to ask the same question I've been asking everybody. Can you give me an example of a service that in your practice you would morally object, or previous practice, I guess, you would morally object to providing to someone?
I can give you things that I would personally object to, things that I've helped other people work through. For me, the classic is the person with Jehovah's Witness who won't have blood. I mean, that's a decision you have to make. Are you willing to put that child through, when I was a scoliosis surgeon, that child through the risk of having a transfusion? Or should they go somewhere else where they may or may not be willing to do that? I've done it both ways. I've talked to the families what my beliefs are. Are you willing to work within my belief system that I will give you your child blood rather than let them die, or do you want to go somewhere else? And I've had people choose both ways. Choices are more than one way. So,
Okay. So, thank you for that. And then my other question is, as an earlier testifier mentioned, we don't list specific services in the bill. And I understand the reasoning for that, but I also am concerned about, we'll say you're the patient and you go in and you need some kind of treatment from a physician, and they say, oh, I saw him talking about this on the news, or we saw that he was at the legislature, and I object to providing this person care based on my moral beliefs. How are we protecting the patient from broad discrimination? Because we don't list specific services in the bill. So anybody could object for any reason to providing a service. And I understand what Senator Merman said about it not being patient specific, it's service specific. But how are we protecting the patients in this bill from discrimination in these cases?
that is a very complex question. I'll try and answer as much as I can. If I don't do it, please. The number of times this come up are relatively small.
Mhm.
for one. There are a variety of opinions and beliefs within our medical system. Our system of children's, for example, has people from all over the world, all different religious backgrounds. There's different ways to do that. I don't personally, when I have someone approach me personally or someone else who has a specific thing they want, they come to me asking my opinion. And opinion's what we do in medicine. We don't claim to have all the right and wrong answers. If I were practicing the same way that I practiced 45 years ago, I'd be complicit in malpractice. I don't do that. We learn, we grow, we change. So my obligation to my patient, I think every physician, every nurse is to do the very best we can and let them know, do we believe that's going to help or harm them? And do I believe that this is moral and ethical? If I were asked not to do things that I don't believe in, I would not practice medicine, because that's not what medicine is. It's about being honest with your patients and their families and saying, this is what I believe is the right thing to do. This is what I'm comfortable doing. I think you're wrong. There are other people, there are other, in this day and age with the internet, I have patients from all over the country, all over the world to come to find me. That's not because somebody's referring them to me. It's because there's so much information available about who can provide what services and where, that it's pretty, the argument about not doing a direct referral is kind of out of the question right now in my mind.
Okay. And then when you say, sorry, just one more question, Chairman, I appreciate that. Thank you. When you're, when patients are consulting with you about what is the right thing to do, does a physician not have the responsibility of providing them with information about what the right thing to do is based on their health and not based on some religious or whatever? I mean, you're there to provide medicine, not to provide
But what I-
perspective from religion or perspective from any kind of moral belief. It's the practice of medicine
my-
based on the patient's health outcomes and not necessarily what is morally objectionable.
But
Correct.
when I take the Hippocratic Oath, I take an oath to do no harm. That's based on who I am, how informed, what my belief systems are. I believe there is black and white. I think there are decisions you make about, is this reasonable? Is this in the best interest of this patient's health? That's a judgment I make based on everything I am, my experience and background. Those things change over time with experience. I don't believe absolutely everything I did when I started my practice, but I am who I am. I owe it to my patients to be honest with them. And if they take that away from me, then I can't be the kind of physician I would want to be or that I want my family to have.
Okay, thank you.
Senator Kavanaugh.
Thank you. Thank you for your testimony. I wanted to follow up on, Senator Day asked that question about a procedure or something that you would deny. And you gave a great example with a patient that's Jehovah's Witness and blood transfusion. But do you have that in your practice and this wasn't enacted? Were there any repercussions for talking with a patient or their parents? Because you did pediatrics, correct? So in talking with the patient's parents and saying, this is the course of treatment, it conflicts with your religious views, but this is the course of treatment that I would pursue as your physician. I mean, I guess I don't see how this would have protected you differently. It sounds like you were doing your job.
I think the world has changed, though. I mean, when the State of the Union address says you're going to be mandated to do these things, that world I grew up in didn't say that. I think the issues are much more complex than they used to be. And I'm sorry, I got away from your question.
Oh, the example you gave, I thought was a really excellent example of when you have to use, whether it's your judgment or your expertise, or you said your belief system, you were confronted with a belief system other than your own and your profession.
Yes.
And the way you handled it, this bill wasn't enacted. And if somebody had that exact same, like you said, times have changed. If someone had that exact same interaction today without this bill enacted, and I'm not a doctor, so I don't know if this is right or wrong. I'm asking you. I don't see how they would be in conflict with doing no harm and living up to the Hippocratic Oath and providing the best care possible. Like I don't see a religious belief being necessary to protect you in that.
But I thought the point of this was because I told that family I wouldn't do that procedure, I'm treating them differently than other patients with scoliosis.
You told them you would do,
I wouldn't do it.
you wouldn't do blood transfusions.
Or if they wanted to have the surgery done without blood transfusion, they go to see someone
Oh,
else.
I see. They wanted, you would do,
I would do it if they would be willing to have blood.
right, okay,
If
yes,
they weren't willing to have blood, they would have to go somewhere else.
right.
If they absolutely insisted that I do it, I'd have to tell them, my conscience would tell me I would give them blood.
And
It's a
your,
really complex
and
thing.
your conscience would tell you to give them blood based on your medical
I would
training.
not allow the child to die based on my medical training.
Right. So again, this would not protect you in any way, shape, or form. You are living up to your scope of practice, your training, your Hippocratic oath. I think what Senator Day is trying to get at is, and I as well, I'm trying to understand what situations, because they're not detailed here, what situations are we seeking to protect? And in your situation, even today, that's still protected because you are providing a standard of care. And as long as you're providing a standard of care, you don't need this.
There's a lot of controversy related to that particular scenario to this day. There's a lot of legal things.
Right.
There are many other things I could give you as examples of why this bill is needed. I was asked to give one.
If you'd like to, please feel free to give a second example.
Sure. I mean, we in medicine have been able to work through a lot of things together with common sense. You know, we have a policy called a DCD policy where
What does that stand for?
deceased, but not, I can't remember exactly. It's when an individual is brain dead.
Okay.
Deceased cardiac donor.
Yes, thank
Deceased
you.
cardiac. Can you say that for the record?
Deceased cardiac donor,
Thank you.
where the individual is legally brain dead and very clearly is, and the organs are harvested before the heart stopped.
Okay.
Now, to me, that's a very moral, acceptable thing. We made a policy, though, because there were no protections like this law to say that people could be excluded from that if they found that morally reprehensible and ethical. So there are ways that we've been doing it piecemeal. With the new challenges, with a lot of things that are coming up there, people have very valid moral concerns. And we could use all those examples. Gender identity right now is obviously the hot button topic. A lot of people feel very strongly about that on both sides. I think we need to respect the opinions on both sides until the science catches up.
So with the DCD example, you said that policies were created,
Put in
into
place.
place. Who does that?
That was in a hospital level. And I
Okay.
think that's one of the things we have to protect is make sure we represent our hospitals and our other facilities too. And I think this bill does that.
Okay. That's very helpful. Thank you for that clarification.
Other questions, Senator Reapy?
Thank you.
Yes, sir.
Dr. Esposito, welcome. I know you as an excellent physician from Children's and an individual of high quality and
Thank you, sir.
character, and I respect you so very much. My question is this, not so much at you, but as the residents that you see, the medical students that you talk to, and you talked a little bit, or some of the testifiers before have talked about the contradiction, the challenge of should they go into medicine or should they do something different with their life? Can you give us a little insight in terms of the degree of that anxiety, if you will, that you see in younger physicians coming on?
Yeah, I think Senator Merman, if I may regress back, that gave numbers on those things, which were pretty compelling to me. I know I'm speaking only from my own experience,
Sure.
where I've mentored and counseled a lot of individuals. And some of them have been told, if you will not do this procedure, which is maybe 0.5% of all the stuff that specialty does, you can't be in this residency.
Wow.
They used to do something else. And for me to have somebody, if it is so important you do that one procedure and you'd be an outstanding physician in that specialty for 99.5% otherwise, I think that's bad because that's taking a choice away from people. What kind of individual do they want to take care of them and their families? So that's the kind of anxiety I'm seeing. I'm seeing them go into specialties they don't like necessarily, they're not their first choices because they're frightened. Are they going to make me do these things as I go forward?
Mhm.
And I think that's my answer to your question, sir.
Thank you. Thanks for being here.
Thank you, sir.
Other questions from the committee? I see none. Thanks for coming today. Next proponent. Good morning.
Trying to find a spot where I can touch the ground here. My name is Francesca Ursua. I'm Francesca I'm a current family medicine resident and will be beginning my fellowship training in obstetrics in July. I speak on behalf of myself, and none of my comments or statements reflect any of the opinions of the institutions for which I serve, including the U.S. government and the Air Force. As a minority female, it is with grave earnestness that I say that I am most fearful of and have experienced more discrimination against my conscience than I have against my race or my gender. Conscience, defined as the inner sense of right or wrong, must be protected throughout all levels of healthcare. In the hierarchical structure of medical training, it's crucial that the trainee's conscience is not seen or treated as less right than the conscience of a supervisor or attending or other authority above them. My colleagues and I have been refused training opportunities, looked down upon, and berated due to our consciences. Medical students and college students have approached me saying that they are losing hope in believing that it would be possible to pursue a career in medicine without their conscience being compromised. If our trainees and our prospective trainees lose hope, we lose the future of medicine. As a current resident in family medicine and a future fellow in obstetrics, I'm here to be a voice in defense of current and future trainees that desire and hope to practice according to their conscience. Thank you for allowing me to speak today.
Thank you. Questions from the committee? Senator Kavanaugh.
Sorry, I think I was going to steal your question.
Go away.
Oh. What have you objected to in your training?
Sure. One of the common ones that I do not do is prescribe any sort of hormonal or device contraception.
Okay. And you're going into obstetrics. I'm not going to say the word right.
Obstetrics, yes.
Obstetrics, thank you. Okay. So that's you're a resident in family medicine and you're going into obstetrics and you conscientiously object to hormonal prescriptions. Thank you.
Yes.
Other questions?
Thank you. Thank you, Senator Walls. Can you talk a little more about where this pressure is coming from? Is it from professors, colleagues, the world? Just can you give us a little insight?
Sure. Generally speaking, yes to all of the above.
Yes, you all above? Okay. Thank you.
Other questions? I see none. Thanks for coming today. Next proponent.
Good morning, members of the committee. My name is Sandy Danek, S-A-N-D-Y-D-A-N-E-K, and I'm Executive Director of Nebraska Right to Life. And I come before you today in support of LB 810. Many medical professionals do not want to be forced into participating in certain controversial technologies and treatments, such as abortion, assisted suicide, or unethical research. By providing conscience protections, LB 810 would ensure that Nebraska does not lose well-trained medical professionals who wish to exercise their professional judgment for the best interests of their patients, born and preborn. Nebraska medical professionals guided by the Hippocratic Oath should not be subject to hostility or coercion because of their ethical, moral, or religious beliefs, and should be able to care for the sick and suffering without fear of negative career or legal implications as a result of the care they provide their patients. When deciding which medical provider is best for one's care, Nebraskans will often consider a physician's moral and ethical standard of medicine. Some would not consider going to a physician who believes in the taking of innocent human life by either performing or supporting abortion or assisted suicide. and Nebraskans should be allowed to make that judgment. Medical conscience is a civil right worthy of legal protection, which is vital to providing medical care to especially the vulnerable. More and more healthcare workers have been coming forward with stories of intimidation, isolation, and discrimination because of their convictions. Medical conscience protects the health and dignity of all patients and empowers diversity among medical professionals. The Medical Ethics and Diversity Act offers that protection. We ask that the committee advance LB 810 out for full debate. Thank you.
Thank you.
Questions from the committee? Senator Kavanaugh.
Thank you. Thank you for being here. Assisted suicide is illegal in Nebraska.
Yes, it is currently, but we do see it growing throughout the nation.
Okay, but it's illegal in Nebraska.
It is currently.
So this bill would do nothing for somebody objecting to assisted suicide because they'd be committing a crime.
It's example I use because it is coming in our direction. It is growing in the nation.
Okay, but currently
Yes.
it's illegal. And as we previously discussed, this actually would not impact abortion unless you wanted to go work at an abortion clinic, which
That's not true, Senator. As a matter of fact, I stepped out of the room to verify what I know, that abortion is legal in Nebraska hospitals.
it is legal.
Yes.
Yes.
And it can be performed in Nebraska hospitals.
It is legal and it can be performed. It is, however, against the policies of the hospitals in the state of Nebraska.
That's not true.
What hospital?
Well, I don't want to say which hospital it is because it's a Nebraska hospital here in Lincoln. And I stepped out of the room to call. I worked at that hospital years ago. So,
And they perform abortions.
and if you'd let me finish my comment, I called this medical professional and I said, please clarify for me what I know to be true, that if a physician wanted to perform an abortion in your hospital, could it be done? Yes, it could be done. It is not typically done because there are abortion facilities in the state now that provide that service. But it could be done if a physician chose to do it.
They don't have a policy prohibiting it.
No, they do not.
And you don't want to say what hospital it is because,
Brian East.
okay, Brian East does not have a policy stating that you cannot do elective
Exactly.
abortions.
Exactly.
I'm just saying that so that they have the opportunity to come in and give us
Mhm.
an answer on
This
that.
is a high-level executive in the hospital, so
Okay,
I would trust your
because-
judgment.
I know for a fact that the hospitals in Omaha have policies that prohibit elective abortions, that you can only get an abortion in a hospital setting in Omaha if your life is in danger.
I can research that for you and find that out.
I don't need you to research
Okay.
that. I know for a fact that that is the case. So I guess we will ask other hospitals to let us know if that is not the case with them. But
It's just commonly not done, as I
Okay.
understand it, because of the freestanding abortion facilities like.
so
Planned
do you know of an instance in a hospital setting in Nebraska where somebody has objected to providing an abortion that was not an emergency?
I do not directly know that. I would have to check with my sources to find that
Okay,
information.
so we don't have, so assisted suicide isn't legal. Abortions, we are not aware of any instances of anybody being forced to perform abortions in a non-emergency setting. So what is left? What are you trying to protect by supporting this bill?
Well, there are a couple of different things I could cite example for. So as I said years ago, I worked at this hospital. And when you would see the daily surgery schedule, you wouldn't necessarily see it openly stated as a termination of pregnancy. Perhaps you would see it as a DNC.
I'm asking
I just
that
wanted
we-
to clarify that.
Right, but I'm asking that we put a pin in abortion and assisted suicide. I'd like to understand the scope of what you think this is helping.
So I think others have commented to this, and I would say the same thing. It's indirect in terms of people that I know, that I've communicated with, that have assisted us in the work that we provide. It's very underlying. There's definitely an outward discrimination that comes when your position is known that you do not support performance of abortion. So, for instance, I had a OBGYN resident that I communicated with, wanted to seek her testimony, and she was concerned for the repercussions she might suffer in her setting if she were to come out
But
outwardly.
This would not protect her.
No, I'm just trying to explain, though,
Okay.
that the discrimination, the pressure that these medical professionals are feeling are very evident.
Okay, I appreciate that. What I'm trying to understand in this bill is what it does and who it's protecting and in what way.
And I think the medical professionals that have testified and will come after me can address that more directly.
Okay, thank you.
Any other questions from the committee? Seeing none. Thank you for
Thank you.
coming. We'll take the next testifier in support of LB 810. Welcome.
Good morning, everybody. Excuse me. My name is Ward Greisen. That's WARD-GREISEN. And I am testifying in support of 810, LB 810. So our healthcare industry has fallen into the phenomena called groupthink. For those that are not familiar with the term, it is used to describe suboptimal decisions that are made by a group due to social pressures. There are 8 symptoms used to identify when groupthink has, or when a group has fallen into groupthink. Invulnerability. Members of the group share an illusion of invulnerability that creates excessive optimism, encourage abnormal risk. Rationale. Victims ignore and discount warnings and negative feedback that may cause the group to reconsider their previous assumptions. Morality. Victims ignore ethical and moral consequences of their decisions they believe unquestionable and immoral in their group. Stereotype. Members of the group possess negative or stereotypical views of their quote-unquote enemies. Pressure. Victims apply pressure to any individual who momentarily expresses concern or doubt. Members are not able to express their own individual arguments against the group. Self-censorship. Victims avoid deviating from what the group consensus is to keep quiet. Illusion of unanimity. Victims share an illusion of unanimity that the major view of the judgments of the group are unanimous. Mind guards. The victims of the groupthink protect the group from information that may be problematic or contrary to the group's view, decisions, or cohesiveness. Even well-intentioned people are prone to making irrational decisions when faced with overwhelming pressure from the group. How can groupthink get started? Well, here are 3 main ways. Group identity. It tends to occur more when a situation where group members are very familiar with one another. When there is a strong identity, members among the group tend to perceive their group as correct or superior while expressing disdain or disapproval toward an outside coalition. So examples of that is lack of diversity in the industry. We see consolidations happening all across the board, whether it's in insurance companies, whether it's in pharmaceuticals. And so we're getting a group identity and we're lacking diversity. Another influencer is leader influence. And who's the leader in this particular case? We see pharmaceutical companies being a huge leader in this case. They're spending billions on lobbyists and voting to doctors and so on and so forth. And the last one is stress. Stress from social pressures can also cause groupthink type scenarios. So what is a recent example of groupthink that would apply to this bill? I think the opioid epidemic is one of those. My wife's a pharmacist, and during that time, 10 years ago, she was working, it's over-the-counter type stuff. She knew the harm that these opioids that were getting prescribed by doctors was causing. But she could do nothing about it other than follow what she had to do as far as an employment standpoint. Even though she had people coming into the pharmacy, she knows we're getting prescribed, and I know I'm at a red light, so let me finish my thought, please.
Really briefly, yeah.
Yeah, okay, I will. Getting prescribed volumes of the drug or levels of the drug that would literally kill somebody. But yet she could do nothing about that. So it is for that reason that I am in support of LB 810.
Thank you. Any questions from the committee? Seeing none. Thank you for coming.
Thank you.
We'll take our next testifier in support.
Good morning, Chairman Hansen and members of the committee. My name is Nate Graz, Nategrazz. I'm testifying in support of LB 810 on behalf of the Nebraska Family Alliance. Respect for the conscience of every individual and for individual differences and deeply held beliefs is an essential aspect of our free society and the practice of medicine. LB 810 protects diversity of belief within the medical profession and ensures that medical providers are never forced to participate in procedures or treatments that conflict with their ethical, moral, or religious beliefs. Federal law and the Professional Code of Ethics and the bill itself rightfully require medical providers to provide examinations and treatments to anyone with an emergency medical condition. This bill does not change that. It simply protects providers from being required to perform a specific procedure if doing so would violate their conscience. It is unsurprising that in a diverse and pluralistic society like ours, that there are different sincerely held beliefs on a wide variety of issues, including in the medical field. But we should all agree that medical providers should not be forced to choose between their ethical, moral, or religious values and their life's calling to practice medicine and help people heal. Medical conscience laws like LB 810 promote a diverse medical field that welcomes people from different backgrounds and faiths, leading to more nurses, doctors, pharmacists, and other healthcare providers. We encourage the committee to advance LB 810 so that the public policy of the state of Nebraska is to protect the right of conscience for all of our medical providers. Thank you.
Thank you. Are there any questions from the committee? Seeing none, thank you for testifying. Is there anybody else who wishes to testify in support of LB 810?
Thank you.
Welcome.
My name is Edward D. Simone, PhD, EDWARD-DE, capital SIMONE. And I'm here to speak in favor of LB 810. I appreciate the opportunity to do so. So I've been a pharmacist for 51 years, licensed to practice in Nebraska. I've spent the last 46 years as a pharmacy educator. I'm a member of Pharmacists for Life, Business and Professional People for Life, and the Catholic Medical Association. I am speaking for myself, however, but I can state with certainty that my comments are representative of pharmacists who believe in the right of conscience as a core tenet of how they live their lives and serve their patients in the practice of pharmacy. The past 25 years, pharmacists around the country have been fired for refusing to fill prescriptions for various drugs based on perceived harm to the patient and/or unborn child. These case decisions were made based on informed conscience and a do no harm commitment as a healthcare practitioner. In 1999, levonorgestrel was approved for use as an emergency contraceptive known as the morning after pill. And since then, that accelerated this problem because it acts in part as an abortifacient drug. Two cases that I worked on as an expert witness, one in Illinois, referred to by a previous speaker, when the governor said that the right of conscience does not apply to pharmacists in Illinois, issued an executive order to force all pharmacists in the state, as well as the pharmacies, to stock and dispense emergency contraceptives. And a pharmacist in a number of chain pharmacies, in particular Walmart, Walgreens, CVS, were fired for refusing to sell or dispense it. Ironically, Illinois has one of the best conscience acts in the country, as we heard previously. In the end, the courts agreed that pharmacists have a right of conscience according to the law. And as well, in the second case, pharmacies also have the right not to stock them or sell them. That's the Moore-Fitz citation that's on your document. After that, Washington State, where the governor tried to force pharmacists to dispense all drugs regardless. And there's an amicus brief in there by pharmacists as well that addresses that case. The American Pharmacists Association has a conscience clause, a conscience policy. I've been a member of the organization for over 50 years, and I was a member of the House of Delegates that passed this in 1998. And it says briefly, APHA recognizes the individual pharmacist's right to exercise conscientious refusal, supports the establishment of systems to ensure this, without compromising the pharmacist's right of conscience. I know my time is up, so that's why I'm a professor, so you have plenty of material to read.
Yeah, great. We have homework, huh?
Yes,
All
sir.
right, all right. Thank you for your testimony. Is there any questions from the committee? Yes, Senator Kavanaugh.
Thank you. Thank you for being here. Were you educated at Creighton University?
No, ma'am.
Okay. I was just curious because you have Creighton University listed on here. And so I didn't know if that was,
No, I'm a New
listing it-
Yorker.
I'm sorry?
I'm a New Yorker.
Okay. All right. So that's not part of your education credentials. Is
No.
what I was trying to ask. Thank you.
You're welcome.
Senator Repeat.
Thank you. The University of Nebraska has reported that a low enrollment of students in the School of Pharmacy. I don't know whether Creighton is experiencing low interest, and if some of that interest is a matter of the ethics and the concern as to what the previous testifier talked about, his wife having to fill opioid prescriptions, which overrode her conscience. I don't know, tell me if you can, what your perception is why more students aren't going into pharmacy.
Well, it's multifaceted, I can tell you that. We look at the, applications and admission. Certainly, one aspect of this is workload, and the COVID epidemic has really accelerated that problem. But the workload that pharmacists have to work under has just been debilitating. If you see the paper every day, we have the same problem in hospitals with nurses and physicians. Everyone in healthcare is suffering from that. So I can't say that definitively that this conscience issue has contributed to that. I can tell you, I lecture every year in our ethics because we have a pharmacy ethics course. And my particular lecture is on this topic, conscience, right of conscientious refusal, and all the issues pertaining to that. And it's after that I get contacted by the students who are now getting in the third year, who are getting ready to sign up for their rotations for the fourth year. And the questions that I get is, I don't want to dispense these things. I don't want to be involved in this. What do I do? So I put them in touch with the appropriate people to help deal with that issue. So I can tell you, they're students, so a lot of times these things don't come up until we discuss it in the classroom. And so once that discussion occurs, then they find out, oh my God, I didn't even think about that. And so that is an issue for many of the students. And I've talked to medical students about, in the same way, particularly those interested in OBGYN. What do I do? And so that's a problem.
So new students considering pharmacy, is that a point of discussion before they make a 3-year commitment and find out if in your class at kind of at the end, it's maybe, I didn't know that.
No, that's an issue. If the applicant raises that question, we certainly will address that and answer that question, but it's not something.
You're not trying to scare them off.
No, not trying to scare them off.
Okay. Thank you for being here.
Any other questions from the committee? Senator?
Thank you, Chairman Hansen. And thank you for being here today. So the Creighton University that you have on your packet that you gave out, that's where you are a professor, is that correct? Is that where you're
Yes,
teaching?
I've been there
Okay.
34 years.
Okay. And then, so you mentioned Plan B earlier, and the objection there is that you see it as an abortifacient. Is that correct?
If you look at the medical literature, it says the mechanism of action is still unknown. Sometimes it acts as an abortifacient, sometimes it acts as a contraceptive, depending on a very narrow timeline of when the individual takes the drug. And so when I talk to the students, I have what I call the gun and bullet analogy. I said, if I take a gun, put one bullet in it, spin the cylinder, and hand it to you, will you shoot someone in the head if I ask you to do that? And they look at me and, no, I'm not going to do that. I said, well, that's the same thing. We don't know when this is an abortifacient and when this acts as a contraceptive. And since I don't know the answer to that question, I'm not going to dispense that because I'm not going to participate in that process. It's that simple.
Okay, and so I'll ask the same question I've asked a couple of other testifiers. What protections are in this bill for people who are seeking medical care or prescriptions and their rights to receive that when they are asking for it, and protecting them against discrimination based on the failure to provide services when asked?
I'm not sure I understand who you're referring to.
The patient. So
Okay.
if somebody asks, it has a prescription filled for contraceptives or opioids or whatever it might be, what recourse is there in the bill for people who feel as though they've been discriminated against? Is there any?
I can't answer that. I don't know exactly what those protections are. However, if we go back to that Illinois case, prior to that time, the pharmacies in question had signs for the patient, or they had two pharmacists there. When they knew one would dispense it, if the other one wouldn't, you can step away. So the onus was on the institutions to provide for situations in which this drug would not be dispensed. And we know, let's be honest, we don't see this in the paper every day. This is not a major, headline type of issue. This is something that happens quietly between two individuals in a given situation. And my recommendation, certainly to our students, is that before you take a job, you need to ask your potential employer what happens in this situation. That's one recommendation that I make to every student in class. The worst time to decide what you really believe is when you have a prescription in your hand. And so assuming this bill gets passed into law, I would encourage the facilities that provide for these drugs to be proactive so that they want to protect their patients, fine. And that's part 2 of that pharmacist conscience clause that I read. And I voted for that. I was okay with it because it said pharmacists have the right of conscientious refusal. But part 2 says systems should be in place to take care of the patient. But whatever systems are in place should not impinge on the pharmacist's right of conscience. So I think under the APHA policy statement, the onus again is on the institutions to do something to protect, to assist their patients. And I'm okay with that. As long as, because in Catholic teaching, formal cooperation is a violation. I'm not going to call somebody up and say, well, you filled the prescription. I might as well do it myself. But if the institutions provide for that, I can step away and say, I'm not formally cooperating with this issue. And I'm okay with that.
Thank you. I appreciate
You're welcome.
that.
Senator Miller.
Thank you, Chair.
Yes,
I'm
sir.
sorry.
No problem.
So can you walk me, I'm kind of piggybacking off that. Can you walk me through this? So you, as a pharmacist, you receive a prescription and you have a conscious objection to it. What happens next?
Okay. If it depends on who I work for, let me put it that way. So let me give you a personal example because you were asking personal examples. When I lived in Indiana before I came here, I was teaching another university, but I worked one day a week. But I went to this hospital that was close to where I lived, and I said, I'd like to work here one day a week, if that's okay. And I did the interview and everything, and the pharmacist in charge says, we'd like to hire you. I said, okay, but I have one condition. I don't dispense any meds that are abortifacients. And his response to me was, I want you to come here, so we'll work with you so that doesn't happen. And it was never a problem. As a matter of fact, I got a prescription once in the hospital for an abortifacient suppository, and I went down to the ER, I talked to the ER physician who prescribed it, and he said, well, the woman has had a partial miscarriage, and we want to deal with that. No problem. I went up to the pharmacy, I filled a prescription and brought it down personally to the ER. So there are ways to handling that. In the Illinois case, prior to this time, Walmart, Walgreens, and all those, they had signs up. So if they only had one pharmacist on duty, it said, if the pharmacist cannot fill your prescription, call this number. The institution took care of the problem. What happened in Illinois is when the governor issued an executive order, all of these companies got squeamish and they didn't want to be involved in lawsuits. So they just went in and fired the pharmacists who wouldn't do it instead of fighting this out. Ultimately, the courts ruled that the Illinois right of conscience includes pharmacists and protects them, and it also protects them from any type of retaliation. And that's what we're looking for. That's what's in this bill. Not just the protection of conscience, but protection from a retaliation. So I don't know if I answered.
Oh, yeah, of course. I mean, so maybe what I'm getting at. So in your 30 plus years of experience, you've never seen a patient not receive their prescription.
I'm sorry.
So in your 30 plus years of experience, you've never seen a patient not receive a prescription in one way. They can go to another pharmacy or.
Right. I've never seen that. Now, I've been teaching for 44 years. So my involvement, the first 12 years of that, I did work in hospitals. Prior to that, I was in a community pharmacy in suburban Philadelphia. So, but it's never been an issue in my experience.
Any other questions? Senator Repe.
Thank you, Chairman. We were talking, some of you were talking some about the employment. It would seem to me, and now once you respond to this, the American Disabilities Act requires employers to seek accommodation for employees. So wouldn't employers, be it pharmacies, hospitals, have a legal responsibility to try to accommodate, whether it's a physical disability or it's an objection to a certain procedure? It seems to me like the employer's on the hook here to make some concessions to make it work.
I'm not an attorney, so I can't, I'm not familiar with the wording of that type of legislation, certainly. But that's exactly my point. I think, one, if the wording of that law says that they should be making accommodations, and they should know that and make accommodations. But on the other hand, there is an onus on pharmacists in particular or physicians, healthcare practitioners of all types. If you're going to put yourself in a situation where something like this might happen, I think they need to be proactive and say, look, just like I did in the hospital, this is my situation. If you want me to come here and work for you, this is the condition that I have for employment. Will you make the accommodation? The hospital decided to make that accommodation, so I never had a problem in the next 9 years or so that I worked there. So, yeah, I think there's a requirement on both ends. I think there's a requirement on the part of the employee to make their feelings known if they know they're going to be put in a position like that. I hate to plead ignorance, so think about, what position you're going to put yourself in, and then make sure your employer is aware of it. And in regard to your previous question with numbers of pharmacists, for example, there's plenty of jobs out there. If somebody won't hire you, somebody else will. Right now, I was in a pharmacy yesterday and they apologized because they're short-staffed. Everyone is short-staffed. There are plenty of positions, so deal with it.
Thank you.
Thanks.
Any other questions from the committee? All right, saying
Thank
none,
you.
thank you for testifying. Is there anybody else who wishes to testify in support of LP 810?
Hi, my name is Lloyd A. Pierre Jr., LLOYD, A for Arthur, Pierre, Pierre, Jr. I'm here in support of LB 810. Good day, Chairman Hansen and committee members. My name is Lloyd A. Pierre Jr. I'm a co-founder of a faith-based clinic here in Omaha, Nebraska. I took the Hippocratic Oath to first do no harm when I became a doctor of medicine in 1994. I am now a board-certified family medicine physician since 2001, and I've done limited hospice and palliative care medicine. When you think about this issue and others such as freedom of speech, freedom of religion, freedom of press, you ultimately realize that those, like freedom of conscience, are simply about freedom. I started a primary care clinic in Omaha, Nebraska, more than 10 years ago after retiring from the United States Air Force. While I was active duty, I went to many places around the world. I saw how medical care was delivered in austere areas of the world. Many people around the world have no choice in the care they receive. This is due to several factors too complex to get into here. However, I noticed, in my opinion, that when leaders of countries do not make conscientious medical care delivery a priority, excellence in medical care suffers. And thus, so do the people in those countries. People around the world saw the U.S. as a model in medical care delivery and would travel here for better medical care. They still do. While I was stationed overseas, many foreign medics told me how lucky I was to practice medicine in the United States. Yet, when I came back home, I noticed that many medical institutions here were starting to lose that desire for excellence. In some institutions, conscience and science were not priorities anymore. I was shocked to find out that many medical schools were no longer requiring doctors to take the Hippocratic Oath. Many doctors were even arguing against the oath. That's one of the reasons why I started a medical clinic that would offer dignified faith-based medicine with a conscience that would first do no harm. During the recent pandemic, we have had droves of patients switch to our clinic because they were being pressured into certain forms of medical care that conflicted with their values, with their principles, with their well-formed conscience. I would hear, and I still do, Dr. Pierre, thanks for offering this type of medical care. We have patients from all walks of life, ages, colors, religions, sexual identifications, and they know when they sign in for care that we deliver faith-based care. And they acknowledge there are certain services we cannot provide. That's upfront before they even start seeing any one of our providers. They understand what the expectations are, and they still take that care. Why do they take that care? I've asked some of the atheists that are in our clinic, and they say, because we realize that you guys will respect our rights as well as those who are not Christian or not Jewish. Unfortunately, as many of you are aware, disastrous events happen in our past that illustrates what happens when medics ignore their oath to first do no harm. Medics ignored their oath to exercise a well-formed conscience when they chose to infect innocent Black men with syphilis without their informed consent.
We have to interrupt you. Sorry.
Yes.
We got the red light, so we're at the wrap up our thoughts.
I'll wrap it up. Lest you say this talk about atrocities infecting Black men with syphilis and torturing Jews in the Holocaust, for example, is over the top. I say it's not. Removing people's right to freedom of conscience opens the doors to a Holocaust. Medics need to be able to have the freedom of conscience to follow their Hippocratic oaths, to first do no harm, to, for example, continue to choose to alleviate pain and suffering as patients are transitioning to death instead of being forced to assist them in suicide.
Okay, I'm going to interrupt you. I think we're pretty good.
Good.
Just got to make sure I extend the same courtesy to everybody else.
Yes.
So.
I think you have the rest of that in there.
Yes, we do.
Because taking away my freedom of conscience ultimately can take away yours.
Let's see if there's any questions from the committee. Are there any questions from the committee? No? You're off the hook.
Great.
All right. We'll take our next testifier in support of LB 810.
Good morning, and thank you. I am Dr. Richard French, R-I-C-H-A-R-D, F-R-E-N-C-H, a doctor of internal medicine from Hastings, Nebraska, where I've practiced for 40 years. Regarding LB 810, which I am in favor of, it involves medical ethics and preserving a right of conscience for medical professionals. This is a big deal for physicians, as you've already heard. All of us live by one set of ethics from society. We live by another set of personal ethics. In medicine, we have a third set of ethics. It's our professional medical ethics. Those may be distinguished in this example. Society's ethics tell us that it's okay to drink alcohol responsibly, socially, but some of us may choose to forego alcohol completely as a choice of personal ethics. Usually these ethics overlap. Sometimes there are some differences, and that's what we have to pay attention to. The Hippocratic Oath that I took stated, first of all, do no harm. But there was a second corollary to that, which said, I will give no medicine to a pregnant woman to abort her child. Interesting. 2,000 years ago, that unborn baby was called a child by the Greeks. Where are we now? At any rate, as you know, doctors are faced with life and death decisions repeatedly. They must weigh the potential benefits of every medicine and every treatment and every procedure on a daily basis. They weigh that potential benefit against potential side effects and risk of harm. This is a process of judgment that doctors must go through every day. Now, however, there are many third parties who desire to control doctors' practices and decisions. Among them, as mentioned, insurance companies, government agencies, pharmacies, pharmaceuticals in particular, their chief objectives may be financial gain or political policy over and above patient welfare. Yet these third parties bear little or no liability or responsibility for harmful outcomes. The responsibility still remains on the shoulders of us physicians. We doctors form different opinions from the same information. So there's often differences of opinion about the same thing. Medicine is not an exact science. That's why we call it the art of medicine. That's why doctors consult one another, why doctors refer patients for second opinions. I'm sorry. But doctors will not work under conditions that violate their right of conscience. That right of conscience must be respected and protected proactively, not after it's already been violated. Thank you.
All right, thank you for your testimony. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hansen, and thank you, Dr. French, for your testimony today. You said you were a family medicine?
Internal medicine.
Internal medicine,
Yes.
I'm sorry. Okay, so you mentioned the ethics surrounding abortion
Yes.
in your testimony, as have several other
Yes.
testifiers. In your practice in internal medicine, do you have anything related to your specific practice that you would object to? Because I assume abortion is not under your practice. You
Correct.
wouldn't be-
But the oath is taken as a medical student graduating from medical school, regardless of where they're going. In my practice, I can relate, we're talking about procedures, but we're also talking about many treatments become equivalent to a procedure. So prescriptions in that sense. But in my practice, the first 9 months of the COVID pandemic, we were told by experts out of our government agencies that there were really no treatments that you could offer a patient. Make sure they wear a mask, make sure they wash their hands, social distance, let's lock down the economy. But for the frontline doctors who were treating patients in ICUs, they were told that we have really nothing to recommend and prescribe and treat patients with. Now, there were dozens of articles, research studies, which came out of Europe, South America, other countries by reputable hospital systems and physicians that said there were benefits to hydroxychloroquine, to ivermectin, and that they were seeing reduced severity of illness and reduced mortalities. So there were frontline physicians in America that first 9 months of 2020 that said, well, let's try hydroxychloroquine. We've got nothing else to give these patients, but we've got to try something. Let's try ivermectin. We've got to try something. And we know that these medicines are safer than the medicines that came out later, remdesivir, that we're now treating people with, that gives 2 or 3% benefit over nothing. But doctors were mandated and threatened if they did prescribe hydroxychloroquine, ivermectin, which I prescribed. I thought, I've got to try something. Let me go on. We know of doctors who were threatened to lose their license because of prescribing those medicines. We know of doctors that lost their jobs in high-level medical centers because they prescribe those medicines. But that's where the right of conscience, medical judgment, medical experience comes into play because medicine is not an exact science. It's got to be dealt with by each doctor's own conscience and best medical judgment.
Okay,
Another
thank you for
question.
that explanation. This bill would not apply to those situations because this bill provides protection and the right to decline a service.
Well, I see this bill without having specific procedures enumerated being open to provide doctors some latitude in what they are mandated to prescribe or not prescribe according to their own conscience, treat or not treat according to their conscience. Proactively, I think your bill should take that into account, that we see things coming down the road that maybe we ought to make some allowance for future problems that are going to arise rather than waiting till after the fact and we've already got a problem that has created issues and driven some doctors out of their practice accordingly, because doctors do not want to be mandated. We're not robots. We don't want to be robots, and you don't want a robot for your physician, I'm sure.
Okay, thank you, doctor.
Anybody else?
So, are there any questions from the committee? All right, seeing none, thank you. Is there anybody else wishing to testify in support?
Good morning, Chairman Hansen and members of the Health and Human Services Committee. My name is Elizabeth Heidt Kozishek, Elizabeth Heidt Kozishek. I'm a clinical psychologist and I've been licensed in the state of Nebraska for more than 25 years. Throughout the course of my career, I've served rural Nebraskans through my work in hospitals, mental health centers, private practice offices, and nonprofit organizations. Protecting the conscience rights of providers is in everyone's interest. Licensure as a psychologist in the state of Nebraska requires adherence to the ethical standards of psychologists of the American Psychological Association. The primary purpose of this is to ensure the well-being of the people that we serve, as well as the public good. The APA Code of Conduct of Ethics states, psychologists respect the dignity and worth of all people and recognize that fairness and justice entitle all persons to access to and benefit from the contributions of psychology and to equal quality in the processes, procedures, and services being conducted by psychologists. And while no profession is immune to impaired professionals, the numerous providers I have had the opportunity to know across this state are genuinely concerned with the well-being of their clients. And they do not take lightly their obligations to fairness, justice, and dignity. And that is why passing LB 810 is so important. In the interest of their clients, psychologists are called by their code of ethics to exercise reasonable judgment and to take precautions to ensure that their potential biases, the boundaries of their competence, and the limitations of their expertise do not lead to or condone unjust practices. Ethical practice requires that psychologists work within the boundaries of their competence and refrain from taking on a professional role when personal, scientific, professional, legal, financial, or other interests or relationships could reasonably be expected to impair their objectivity, their competence, or their effectiveness in performing their functions as psychologists. LB 810 will help preserve the ability of psychologists and other mental health providers to engage in ethical practice. In the absence of such laws, some practitioners, for fear of litigation or loss of employment, will undoubtedly be compelled to violate their ethical code, thus placing their clients at risk of harm. Left without the protection of laws such as LB 810, good, upright, ethical providers may be forced out of practice in our state where the vast majority of counties are designated as mental health professional shortage areas by the Federal Office of Rural Health Policy. Nebraskans need our government to support ethical healthcare providers in our state. We cannot tie their hands and further decrease their numbers by failing to support them in ethical practice. The state licensing board is in place to identify impaired providers and to root out those with intentions to harm or who would misuse the ethics code to justify or defend the violation of human rights. LB 810 supports the practice of ethical providers. LB 810 promotes justice and respect for the rights and dignity of all who seek care in our state.
All right, thank you for your testimony. Are there any questions from the committee? Seeing none, thank you. Is there anybody else who wishes to testify in support? Welcome.
Good afternoon, Chairman Hansen, members of the HHS committee. My name is Tom Benzer, Tomvenzor. I'm the executive director of the Nebraska Catholic Conference. I'll send my more formal testimony later. I just kind of wanted to hit on some points that I've heard throughout. I think one thing that's important kind of up front with this bill is I think it's pretty important to think big in terms of the kind of conscience claims that can be made. This bill isn't just for any sort of one small subset of religious adherents or people with certain ethical values or philosophical values. It runs a spectrum. I think as Senator Merman said in his opening, atheist, person of faith, left, right, you name it. If you've got a conscience claim, then you can come to the table. This bill is protective for you. And so I think that's pretty important. And that's also part of the reason why you can't spell out all the services, because there's a broad array of conscience issues that might arise from any number of different types of people. And I think that's needs to be considered as you're thinking about this. Think big, don't think small. I think there were some things said about, in certain situations, maybe there isn't repercussions where you assert an ethical claim or a moral claim or a religious claim. And I would say that probably occurs where you don't have, a controversial issue at hand. But as we know, the types of issues that are becoming more hotly disputed, just politically, culturally, et cetera, are growing. I often share people this quote. So Ezekiel Emanuel, who's kind of the architect of Obamacare, he had said, this was probably about 6-7 years ago in a journal article of New England Journal of Medicine, basically telling people, look, if you can't do abortions, do those contraceptive services, then you either need to get out of medicine or go practice in an area where you don't have to worry about conscience issues such as radiology. No offense to my friend Dr. Hilger, but let's talk about that, right? Because in other words, go escape somewhere else. Don't practice in the field of your preferred field, maybe the field that you're actually better at. And so we need to take into consideration those kind of things. I will just also say, on the abortion issue, look, even if you don't have those situations arising in the ways that Senator Kavanaugh said, and that directly in abortion, but the thing is, in the bill, it asks the practitioner to state potential medical conscience issues up front, and so that's happening in med schools and residencies and fellowships, in the clinics, in the hospital. So when they state that up front, if adverse action is taken against them, and it does happen, they can sort of use this as well. And finally, I will say, just from the Catholic Conference's side, we've dealt with this issue from the Board of Psychology and the Board of Mental Health Practice at an administrative level. And I can tell you that we've had areas where our faith-based mental health practitioners, they won't do certain types of services, and we've tried to negotiate referral language on that. And there's been no movement on that because the opposition only wants direct referrals. And if you can't do a direct referral, then you ought not be in the profession. You ought to shut your clinic down. And you just ought to get out of the business. And I think that's a pretty bad signal to be sending. So that's all I got. Thank you.
All right, thank you. Any questions from the committee? Yes, Senator Day.
Thank you, Chairman Hansen. Thank you, Mr. Benzer, for being here today. You mentioned mental behavioral health care related to this bill.
Mm-hmm.
What would the services be underneath the umbrella of mental behavioral health care that someone would have an objection to providing?
Yep. So I can just, our experience again with the Board of Psychology and Board of Mental Health Practice underneath the Department of Health and Human Services. The examples there have been typically the attempts by those boards to try to insert, language regarding sexual orientation, gender identity. And we have stated concerns on our side of that to say, if these are essentially going to force, faith-based practitioners who have sincerely held religious beliefs or moral beliefs, or also professional judgments from a mental health perspective, if this is going to force them to engage in things like same-sex counseling, or let's say you've got a client going through like gender transitioning counseling or something like that, this is going to force them to engage in those type of practices. We've always said that needed to have robust referral language so that in those situations, those providers could say, I can't provide the service in this area. That's against my conscience. Those would be examples of things that we had. That all kind of entailed also a fight over what would be an adequate referral where you can't provide the service. And I know that's been an issue here on this bill too, and hopefully we can work through a solution on that. But those would be examples in that context of the mental health field.
Okay, thank you. So one more question. Related to that, there seems to be a little bit of a theme with several testifiers that the major objections are in the areas of reproductive health care, contraceptives, abortion, that type of thing, and then also issues with sexual orientation or gender identity. Do you see it as problematic that this bill would essentially be eliminating access to healthcare for two very specific groups in society?
That's not what the bill's doing. And again, as I said at the beginning of it's allowing a healthcare provider professional to object to a particular healthcare service. And so the bill isn't about, trying to ensure that these people can't have any access to healthcare. And I think to frame the bill in that way is not correct. That's not what the bill's doing. It ensures that, as one testifier said earlier, you're talking a very minimal amount of services in very particular circumstances with probably a limited number of healthcare providers. And so there's a lot of other people out there in the world who will provide those types of services. But the point is that a patient can't demand and force a physician or another healthcare practitioner to have to provide the service that they're necessarily seeking. And like I said earlier as well, I think it's really important to think big on this too. Of course, I think a lot of the testifiers have probably framed a little bit of how this hearing is going so far, but I would invite everybody to ask the healthcare professionals that they interact with, whether they're, again, atheist, whatever political side of the spectrum they're on, because I've seen issues related to circumcision, vaccination schedule, blood transfusion, as you've heard, organ harvesting, gene editing, opioids, counseling centers, gender issues, abortion. It runs a spectrum of things. And so I think to frame the bill as sort of eliminating access to healthcare for certain populations is just the incorrect way to frame the bill.
But you do agree that those are the two major areas here that we're talking about, is gender identity and reproductive health care. And so if we are saying medical practitioners can refuse to provide that type of care, we are essentially limiting access to care for specific groups of people.
Well, what you're trying to do on the whole with this bill is ensure that you have access to all sorts of care, generally speaking, as well. Because like we've talked about earlier, you've got, I think, a number of the physicians who came up already. These are individuals who will provide a number of different services across the board and across the spectrum. But they won't violate their conscience. And if they're forced to violate their conscience, they will do things like quit their job and leave their profession. And so, in other words, without this bill, what you're going to be doing is also limiting access to all sorts of general health care, because those providers are not going to continue in the field. Or one, like you've heard too from residents and students who didn't even want to come to the hearing because they're afraid of the repercussions that they would have from med school or supervisors or fellowships or what have you. That you're going to limit their ability to serve in the field with their conscience intact. So I think that's what the bills are doing here.
Sorry, I have one more question. Okay, so related to that, similar questions to what Senator Kavanaugh was asking earlier. If someone does not want to provide the services required of their profession, maybe that's not the appropriate profession for them to go into. And that, is it necessarily a bad thing if we're saying to physicians, if you are not willing to provide the services that are required of someone who provides those services, maybe you should provide other services?
So that's basically the Ezekiel Manual quote. If you want to go to OBGYN practice, but you won't do abortion or contraception, then you should not be in the field at all. And maybe you should go get out of medicine, period, or go pursue a different profession. But I think the testifiers before this were getting to this point. that's a fundamentally bizarre notion that because you can't provide a limited subset of the services in this area, that you ought to not practice at all. I mean, that is, you
I
would,
don't
you
think
would.
anyone's arguing that you shouldn't practice at all. You're just, it's, if I were to go apply for a job and the job was to, you know, I wanted to be a professor of a particular area, but I
Mhm.
didn't want to teach about a subset of that area, then maybe teaching in another area that I would be willing to provide the entire breadth of knowledge would maybe be a better fit for me. And that's not necessarily a bad thing if we are. Do you
Yep,
see
yep,
where
I
I'm
see where you're going.
Sorry, I'm not.
No,
articulating.
you're making total sense. And again, you're treating everything, I think, here is clear, 100% black and white. And you're not recognizing the fact that in the area of medicine, right, ethics and medicine are going hand in hand. You know, you can't come into the field of medicine and sort of like, well, I'm going into medicine, so now I'm going to put on my ethical coat. And then when they ask me to do something objectionable, I'll take off my coat or what have you, because people's values, their medical judgments, their moral judgments, all those things are intertwined. But I go back to this point about why would we want to tell somebody, here's a place of disputation on medicine or on ethics or on religious beliefs or what have you. And some of the places we're talking about, these are very controversial things. So to treat them as if everybody's got a common judgment about them and everybody is 100% on board with them, I think demeans the fact that there's legitimate controversy about some of these things, ethical, medical, religious, etc. And this bill makes room for all sorts of people with different values on both sides of the aisle, on both sides of on all sorts of sides of the faith sides. It protects all of those people to be in the field so that we have as many practitioners as possible who come to the place of medicine with their whole person, including their ethics, their religion, their philosophical views.
Okay,
Yeah.
thank you.
Yeah, no, thank you.
Any other questions in the committee? Seeing none,
All right,
thank you.
Thank you very much.
Is there anybody else wishing to testify in support of LB 810? Welcome.
Thank you. My name is Alex Stevens, ALEX STEPHENS, and I'm here in support as a proponent of LB 8110. Pluralism is the belief or practice of enabling many different doctrines to coexist. A more modern phrase referring to the coexistence of ethnicities and races is multiculturalism, but that's actually only a subset of the broader liberal idea of pluralism. Pluralism is what protects the patient, and it's this bill that will protect the medical worker. Pluralism is a core attribute of liberalism. That is that freedom of conscience is a fundamental right along with the right of property from which all other rights stem. All sorts of people are driven towards a life of care and charity within the healthcare industry and other fields as a result of their deeply held beliefs. It's why they ended up going into medical practice in the first place. I decided to go into biotechnology, the biotechnology field, as a result of learning about the works of Norman Borlaug and the Green Revolution and my deeply held beliefs to do the most good. Medicine is not an amoral practice. Medicine is an inherently ethical and moral act, one where you can't separate ethics from outcomes, as what outcomes are considered good or based off of your ethics. Ethics are derived from your moral values. Innumerable hospitals, charities, and other healthcare providers are founded by different people of different backgrounds to fulfill their desire to perform the common good. Methodist, Catholic, Jewish, and Baptist hospitals exist all around the world whose sole purpose is to help everybody, not just their denomination. No hospital that I know of has denied care entirely on the basis that someone is not from their tribe, but rather from a belief that the so-called care that the person wants to perform is considered harm by the hospital. This bill puts into practice the desire for Nebraska to be a liberal, pluralistic society where people of different backgrounds may perform the varieties of care they wish while not being forced to perform acts they might describe as barbaric or harmful. Opponents of this legislation might say that this enables discrimination, but the opposite is true. By curtailing the rights of people of faith or the people who have secular beliefs to act upon their beliefs to participate in the healthcare field, you are simply eliminating people from the healthcare field and denying people access to care altogether. You do not create more people who are willing to do care by simply requiring a top-down system of what is and is not ethical. That is not liberalism. That's an authoritarian belief system upon which you believe that the people who are to orchestrate healthcare acts are robots for the purposes of your idea of ethics. Medicine is an ethical act, one that is built around the ethics of the doctor, not the ethics of the government. This law does not enable discrimination. It prevents it from being done by major medical associations and government entities that wish to do things that might not be in the best interests of patients. And the person who knows the patient best is going to be the doctor. Thank you.
Thank you. I always appreciate you coming because you fit so much into such a small amount of time. It's a good job. Any questions from the committee? Okay, seeing none. Thank you.
Thank you.
Is there anybody else wishing to testify in support of LB 810? Okay, it looks like there's no more testifiers in support. If I could I get those who are wishing to testify in opposition to raise their hands, please? Okay, all right. So what we're going to do now, we're just going to take a short, 10-minute break. So it gives us the senators a chance to maybe get something to eat and stretch your legs for just a second. So we're going to reconvene probably about maybe 12:15. We'll be back for opposition.
Okay, I have to go.
Yeah, I'll have my staff just let them know. Thank you. Yep. Well, we didn't adjourn, Okay, everyone, I think we're ready to start. And even if those who are testifying in opposition, if they can even kind of move it to the front a little bit if they want to and kind of line up, it might make things go a little bit smoother. It's up to you. So with that, we will take our first testifier in opposition to LB 810. Welcome.
Good afternoon. Senator Hansen, members of the committee, my name is Dr. Leslie Spry, L-E-S-L-I-E, Spry is S-P-R-Y. I'm testifying in opposition to the green copy of LB 810 on behalf of the Nebraska Medical Association. The Nebraska Medical Association agrees with Senator Merman that a practitioner should be allowed to practice within the dictates of their conscience. However, we also must recognize that patients have rights. It is our duty to the patient, our duty to the patient requires that we facilitate or otherwise arrange for the care of that patient. The AMA Code of Ethics provides that for exercise of conscience, physicians must uphold standards of informed consent and inform the patient about all relevant options for treatment, including options to which the physician morally objects. In general, physicians should refer a patient to another physician or institution to provide treatment the physician declines to offer. When a deeply held, well-considered personal belief leads a physician to decline to refer, the physician should offer impartial guidance to patients about how to inform themselves regarding access to desired services. One of the difficulties of the legislation that has been introduced on this subject over the years is coming to an agreement on what language provides adequate protection for patients to be informed of their options and to be directed to resources to access care they feel best for them. The green copy of the bill does not adequately address the NMA's concern in this regard. The bill provides that a practitioner has a right not to refer, counsel for, or advise with regard to any health care service which violates their conscience. The bill provides that upon request, the practitioner must promptly release the patient's medical records to the patient. The NMA does not feel this meets the practitioner's ethical duties to the patient, especially when a practitioner has a long-standing patient-physician relationship. There is a duty to the patient to discuss all potential options for the patient. I would add that for many patients, they have no idea what services they need or expect to hear that recommendation from a trusted physician source. We have a duty to educate the patient. On the referral piece, I would add that in 2013, the Nebraska Medical Association formed a task force on this issue. And the outcome of that task force was to recommend that when a physician feels that it would conflict with their beliefs to refer a physician for a specific treatment, they should at minimum provide contact information for a third-party entity such as the State Medical Association or local county medical association. I understand that Senator Merman is currently working on an amendment to address some of these concerns. In particular, I know that he has an amendment to align the release of medical records provision in Section 4 with the requirements of HIPAA, and I think that's a step in the right direction. We appreciate Senator Merman being open to the feedback on this, and we welcome an opportunity to continue those observations. Thank you for your time, and I'm happy to answer questions.
Thank you, Dr. Spry. Are there any questions from the committee? Senator Kavanaugh.
Thank you. I apologize. My office is in the tower and there's
running.
Well, we have student groups here and limited elevator access. So I apologize for not being here for the start of your testimony. Thank you for being here. The NMA, you talked about Section 4, which is on page 5. So there's an amendment coming. I also missed the introducer's introduction. So there's an amendment coming that would address some HIPAA compliance concerns.
The amendment would address the referral piece on referral for care that violates that practitioner's conscience. And that language that we've seen, at least tentatively, goes partway, doesn't go enough.
Okay. So as it is written right now, they're not required to do a referral?
No.
And what, it goes part way, what would you like to see it do?
So I would prefer, and the Nebraska Medical Association, that's the policy that came out of our task force, is that we wish to have a specific target for the referral. And that target could be the local medical society, that target could be the Nebraska Medical Association, that target could be any trusted physician organization, so that that patient knows where to turn. If I just turn that patient away and say, I can't do this, I'm not caring for that patient. And so we want them to actually have a target for that. And I think there was a mention earlier, I think Senator Reepe's question had to do with whether or not the NMA has ever supported this legislation in the past. And the answer to that is no. We're stuck on this referral piece. I will not abandon my patient. My patient's conscience and my conscience are on the same plane. I can't impose their will on them, and so I need to make sure that that I value their morals and conscience as well.
I'm sorry to be asking you to catch me up on the earlier part of this hearing, but you said Senator Reepe asked if the NMA has ever been in support of this.
Yeah, there was a question earlier about that perhaps 10 years ago when we were, I think it was 2013 is what I remember, and 2012, I'm looking at my notes, 2012, there was a similar bill brought forward, and we had the similar objection in the past. So our objection to this has been out there for 10 years. And our objection remains the same, that we need specific language on referral. And in the previous iterations of this bill, there was always this notion and allusion to the fact that the patient had to be cared for, and we all agree with that. The patient had to be cared for in the interim. But if there was something that I couldn't perform, then we wanted a specific target of referral. And that target of referral does not necessarily have to be a specific practitioner, but the target of referral could be some, as I said, the both medical societies, the Lancaster County Medical Society and the Omaha Medical Association, Metro Omaha Medical Association agreed that they would take calls, and the Nebraska Medical Association agreed that they would take call for Greater Nebraska as well. And if they would offer their phone number as a contact information for someone seeking information about potential referrals.
Okay. Sorry, may I? Was it represented in earlier testimony that the NMA had taken a different position previously?
Well, so there was in the previous iteration of the bill, there was some discussion of duty of what a practitioner's duty was. We agreed with that statement, but it was never adopted. And so we continue to be opposed to the bill because of this specific issue.
Okay, thank you for that clarification. I do have one more question.
But any other questions from the committee?
Go ahead, Senator Calvin.
Yeah.
We've heard from about the pharmacy piece of this, and I honestly find it a little bit confusing because pharmacists can currently have a conscientious objection, correct?
That's right. I mean, and this comes up quite a bit where I get a phone call from the pharmacist saying they don't want to do this, and but they either provide another store or another opportunity for this, and we call it into a different store.
And does it matter who their employer is? It dependent upon who their employer is? It kind of
No, those are conversations between a pharmacist and myself.
But any pharmacist, like with any national chain, it doesn't matter who they work for. They can work for Hy-Vee, Target, CVS, Walgreens, Walmart. it doesn't matter who they work for, they as an individual pharmacist have the right to refuse currently.
And then they call my office and we figure out a way to around that. And so, as was testified by the pharmacist from Creighton who was here, we figure out a way to do that. And I'm not going to violate anybody's conscience as a result of this. And there's a way to get around some of this stuff.
Okay. I was just trying to figure out the landscape. Thanks for bringing me up to speed.
You
I
betcha.
apologize.
And I didn't take any notes.
I had a bill introduction this morning, so I was a little behind, but thank you.
I might have just one quick question, since I think some of the other senators have been touching on this, and it's more kind of a clarification on some of your testimony. Does the NMA believe that a doctor has to refer an abortion if they have like a moral objection, like a strong moral objection to abortion? Like, does the NMA say recommend that the medical doctor has to refer to somebody else in that case?
No, and in fact, that's the crux of the issue. We didn't want to refer to a specific individual. In other words, if I have a conscientious objection to abortion and I don't want to refer it to someone I know does abortions, then I can get around that by referring to the medical association. The medical association hears the concern. They have a list of docs who are willing to see these kinds of folks, and we maintain that list. So we needed a target of referral. What they said was that they would just hand the folks the medical records and be on your merry way, and that was not enough. That's not good patient care.
Okay, I think that clears up for me, I think, is that you were looking for some language and the specifics to use in an amendment that might
The target of
alleviate your concerns.
our target of referral. We need a target of referral. There is not this nebulous wordage that would go on to say arrange for care. Well, the target needs to be a target of referral. If it's not a specific physician that's a for referral, then it should be through the medical society, and we're willing to undertake that responsibility.
Okay, and so then if Senator Merman does craft some of that language and comes with the appropriate amendment, would you guys, in your opinion, would the NMA probably end up coming out and then a neutral position?
So those words have been have said, come up with language, we will review it, and we will make a determination. But that's what our demand or our ask is, if you will, that we need a target of referral. Our patients don't know what they need or desire. They're just looking for help. And if we can give them a phone number, that seems like a target of referral.
Okay, all right, good. Thank you for answering my question. Senator Beller.
Thank you, Mr. Chairman. A couple testifiers brought up the issue of medical students and residents. I'm assuming you've been around or mentored residents in your time. Can you talk about how you would approach a resident that has some medical conscience?
Well, so I've talked to several of them, and my observation of this is that they're very young in this, and sometimes you don't know what you don't know. And so many of them have strongly held beliefs, and I don't know of a single instance where anybody's been compelled to do anything that they don't want to do. Now, I'm aware of it in other instances around the country, but I'm not aware of it. Now, I know that there are, I can't speak for nurses, I can't speak for other individuals, but I know for physicians, we can usually figure out a way to get around this. But our concern is the patient. We need the patient to have a response, have an assurity that they have access to care. And they don't know what they don't know, and they don't know what they desire, and they don't know what they need. But if they can get someone trusted to give them that information. So what I've told the residents and the students is, keep those strongly held, but, put them up front for us. Let us know what we want to do. And if you don't want to do something, those are considerations you have to make as you're going into professions. I can't vouch for every mentor, professor, or peer that might be out there that might condemn you for it, but those are the breaks of life. I mean, as we get to be physicians, you got to take a few incoming sometimes, because those are the things that teach us how to take care of patients. And I frequently said, every patient teaches me how to take care of the next one. And that's what they ought to rely on.
Thank you.
Any other questions from the committee? Seeing none, thank you for your testimony. All right, We'll take the next testifier in opposition.
So good morning, or good afternoon now, Chairman Hansen and members of the Health and Human Services Committee. My name is John Trapp, John-Trapp. I'm a physician. I currently serve as Chief Medical Officer at Bryan Medical Center. My background is also in pulmonary medicine, critical care medicine, and sleep. I've been in practice in Nebraska for approximately 24 years. I come to you today on behalf of the Nebraska Hospital Association and a number of my fellow hospital colleagues in opposition of LB 810. LB 810 aims to solve a problem that rarely exists in medicine. When it does occur, as you've heard discussion, we find ways to navigate this. At present, when a physician, nurse, or any other healthcare member finds themselves in a setting that they may feel compromised to their personal religious beliefs, they work with a colleague to assume care of that patient, prescribe for that patient, or provide other types of procedural care for that patient. This transition of care is generally seamless, done so oftentimes without delay to the care of the patient. In addition, we do have Title VII in place that does require employers in the healthcare industry to provide a reasonable accommodation to employees who have a sincerely held religious belief. The U.S. Department of Health and Human Services, protecting statutory rights and healthcare rule, implements and enforces federal conscious and anti-discrimination laws protecting the rights of employees who refuse to assist in the performance of healthcare services to which they object on religious or moral ground. Again, we work to navigate this with those individuals within our healthcare system. This bill does not include any protections for the employer that Title VII includes, particularly the undue burden provision, while at the same time significantly expanding the definition of discrimination to include any change in employment, such as putting an employee in a different position where they may not be challenged with some of their conscience. This bill would take away a number of the current options for accommodating this religious belief of the employee. So LB 810 creates more challenges than it solves. It will be difficult to operationalize and is unnecessary government oversight into patient care. Thank you for the opportunity to share the issues identified in LB 810 and for this discussion of medical ethics, which is integral to what we do every day. We believe this bill would have a negative impact on Nebraska hospitals as well as many medical professionals. As you hear from myself and others today, I ask that you do not take action on LB 810, allowing hospitals and medical professionals to continue their great work unencumbered by statutes such as this. I would welcome any questions you may have for me.
Thank you. Yes, Senator Kavanaugh.
Thank you. Thank you for being here, Dr. Trapp. Brian, you work at Bryan Hospital.
I do.
You're going to answer the $1 million question for us today. What's your policy as a hospital? And of course, if you can't answer this, please feel free to let us know that. What's your policy as a hospital of performing abortions that are not medically necessary or an emergency?
We do not credential any provider to provide elective abortions.
Oh, you do not?
Do not credential providers to do elective abortions.
Interesting. Okay. Well, thank you
Now,
for
we
that.
do abortions in limited cases, ectopics,
Yes.
risk to the mother.
Medically
all that.
necessary.
Correct.
Yes.
Now, no OB/GYN, but if those are happening, it does not follow with our hospital policy.
Okay. Also, as a hospital, I assume you follow the law that was passed in 1977 that allows any medical provider to object to participating in an abortion.
Correct.
Okay. Great.
Yeah.
Thank you for
work,
that.
We work with individuals. If they express that concern anywhere along the hospital line, we do work with that individual to put them in a position of success.
Thank you. I just would add on a personal note, you said that you also work in the area of sleep.
Correct.
I think you might have some patients in the legislature by the end of the session.
Okay.
But thank you for answering my question.
Yes, I knew that one was probably coming.
Senator Beller.
Thank you, Chairman. Can you unpack when you say it will be difficult to operationalize? Can you unpack what do you mean by that?
Well, what's coming up, let's look at COVID vaccinations. A lot of different discussion on that, right? And so in the hospital, we will administer COVID vaccines let's say the provider writes a prescription for this, the patient agrees, we have alignment with that. Now imagine that as described in this bill, I think on page 5, they describe a medical practitioner, who that might mean. This includes anybody that's employed by the hospital. So vaccine arrives in, let's say, a box at the hospital. Anywhere along the line, someone could say, I have a conscientious objection to this vaccine. I may not unload it. I may not take it to the pharmacy. The pharmacist may not fill it to the syringe. The nurse may not administer it. So potentially this bill impacts our ability to really deliver great healthcare, particularly for patients who want that.
Okay, thank you.
I might have maybe a couple questions.
Sure.
One, because I just don't know. Touching on what Senator Kavanaugh said. So when somebody does come to the hospital for an abortion, who do you, like, you just then refer them out typically then?
When you say abortion, elective abortion?
Elective abortion, yeah. Sorry.
Generally, they present to the outpatient setting. Oftentimes they are, again, not an OBGYN, they're referred to centers or other places where that might be performed as an elective procedure, as opposed to our emergency room, where if it is endangering the mother, then our OBGYNs do what they do best. They take care of the patient and the mother and work with that patient to determine where do you stand on this and understand that risk. So we spend a lot of time in the patient-physician relationship having a discussion. Please understand what this means, what we believe will happen to you, that this is a medical emergency. If this pregnancy progresses, it is likely to cause you harm or danger.
Okay. And I appreciate that because I was trying to fit that in with the bill when we're talking about referral and how that works and how that work on your end with the hospital. And you mentioned in your testimony, the last paragraph, that this will have negative impacts on medical professionals. Can you explain that a little further?
Well, we have lots of examples of the past several years with regard to COVID and other things like that. You can have a strong personal conviction, and we've heard it may not be based on science. It may not be proven. You may not agree with what literature was put out there. You may, in fact, choose alternate literature. These become really difficult to navigate. And so how do we work together to get the right patient, the right treatment to each patient? And so in the intensive care unit, oftentimes we are faced with ethical dilemmas. We have patients who may have progressed to end of life and still families saying, please do everything. The patient may say, do everything. We have discussions that we don't think this is survivable. We offer other options, palliative care, hospice. But I will tell you at times that we've had to navigate that as well. And we may do things that we feel are probably not in the best interest of that patient, providing prolonged life support, feeding tubes, even though we know this is probably not a survivable illness. So when we have people that may say, gosh, where along the line can I object to this? I mean, that could be anybody in the entire service line because they define this as anybody within the hospital, any hospital employee, clinic employee, medical assistants, pharmacy techs, et cetera. This may make it difficult to say, we have to have the entire team aligned from start to finish on what we're doing. In a case where it is an abortion in an emergent situation, even then, we may still have some people say, I just am uncomfortable with this, and we'll work to switch them out so that people who are comfortable doing that procedure, because those are difficult.
Okay, thank you. Yeah, there's a lot of complexities when it comes to this, especially in the hospital, I can only imagine. So.
Ethics is really a complex issue, and I think you've heard that with the testimony today. And I will tell you, we've found ways to navigate this. You've heard about some of our practitioners who I deeply respect, who have held these deep personal beliefs for many, many years. I also heard, I practiced for 40 years. I've practiced and retired. Almost all those practitioners practiced 30 to 40 years. They navigated this every day. And these moral dilemmas, ethical dilemmas didn't just appear in the last few years. We've dealt with these for decades, and they've navigated that through their practice successfully. None of them quit their practice. They were actually able to retire successfully and do that. So we do that.
Yeah, I think, on their point, I would think though too, I think because of their experience and what they've seen 40 years ago compared to now, I think that it's a lot more of a litigious environment, I think, now than it was 40 years ago. And so I think when they're talking about being proactive with this bill, you're kind of seeing stuff on the horizon. I mean, and so this is ability to protect physicians specifically, I think, and with their conscious objections to certain procedures. So I think now is a different environment than definitely it was 40 years ago, especially when it comes to, opinions and emotion and lawyers and lawsuits. And so I think that might be one of their kind of arguments about why this bill is needed.
And this bill extends beyond even licensed providers to really, again, the entire list on page 5 of anybody who may be involved in the healthcare line.
Yep, I think that's a good point on that one. Any other questions? Yes, Senator Kavanaugh.
Sorry, I realize I probably need to make some clarifications since I'm not a medical professional. I think I was misusing some terms. So elective is anything that's not like an emergent medical emergency, correct?
Correct. I
Okay,
mean,
so when I said that it medically necessary, that something could be elective and medically necessary?
correct.
Okay, because I was
There
kind
are
of,
some pregnancies that may occur in the fallopian tube that we know will result in
right,
eventually risking the mother. We don't wait till it ruptures and causes that fallopian tube to rupture. We intervene ahead of time
right.
and do a procedure that was described, a dilatation and curettage DNC procedure. We do those in anticipation that this will eventually non-viable pregnancy. And if medical science changes at some time, we can implant that somewhere else. Wouldn't that be great?
Yes.
Right now, in talking with our OBGYNs, medically, we can't do that once that pregnancy implants at the wrong place.
So just to clarify for the record, you do perform medically emergent necessary procedures. I was misusing medical terms, so I just wanted that.
We follow the law. We follow our credentialing policy on
Yeah.
that. We don't do the elective abortions that do go to these clinics that you've described.
Right.
All of these are medically indicated, medically appropriate for risk of the mother.
Okay, thank you. I just wanted to make sure I clarified for the record my misuse of terminology. Thank you.
It's good to get that clarification.
Any other questions from the committee? All right, seeing
Thank you
none.
for your time.
Yeah, thank you. We'll take our next testifier in opposition, please.
Hi, committee. Thank you for having me this afternoon. My name is Dr. Echo Kohler, ECHOKOEHLER. I have a Doctor of Nursing Practice degree. I've been a registered nurse for 20 years and a nurse educator for 15 years. I am here on behalf of the Nebraska Nurses Association, speaking in opposition to LB 810. Supporters of LB 810 claim that it will protect a lengthy list of healthcare workers and institutions who object to procedures or prescriptions on moral, ethical, or religious grounds from discrimination, retaliation, or punishment. Nebraska Nurses Association seeks to support the delivery of safe, cost-effective care for Nebraskans, and we recognize the need to provide healthcare services without discrimination. If passed, LB 810 would remove fundamental protections against discrimination on a broad basis. LB 810 will allow healthcare providers to selectively exclude populations from their care and further marginalize disadvantaged groups. Healthcare providers are already able to decline to provide services based on their competencies and training, but ethically they cannot discriminate based on selective personal beliefs. No patient should ever be obstructed from receiving legal healthcare based solely on a provider's personal biases. Conscience bills such as LB 810 lead to dysfunctional healthcare delivery and compromise the quality of care by creating barriers to meet patients' needs. Conscious legislation such as LB 810 also complicates the healthcare system and compromises any united standard of care. The strain this would put on minimally staffed healthcare facilities and patients in rural areas with sparse access to care is unreasonable and unconscionable. NNA opposes violating patients' autonomy and choosing the type of healthcare services they deem most appropriate to their own needs. NNA also opposes legislation such as LB 810 that regresses healthcare into a paternalistic system where the provider is the ultimate decision maker rather than the patient. The Nebraska Nurses Association is the overarching organization for the over 30,000 registered nurses in Nebraska. All nurses are bound by our already established code of ethics and our professional duty to our patients. For these reasons, the Nebraska Nurses Association is opposed to 810, and we ask the committee to stop the advancement of this bill. Thanks.
Thank you for testifying. Are there any questions from the committee? I might have one, again, another clarification question. It sounds like from previous testimony and even the NMA, it sounds like somebody can choose not to treat somebody based on personal beliefs, so long as they refer them?
Yeah. So I think you heard a lot of examples this morning of specific examples from a lot of providers where they already have in their practice experienced all of these different unique situations, and they already were able to make conscious decisions and then effectively refer or provide services in another way. So we already have established ethics committee for really complicated situations in our major institutions. Even in rural settings where there aren't as many providers to have like a formal ethics committee per se, we have staff meetings where we're able to discuss really complicated patient care issues. So if there is one provider per se that has a conscious objection, we're able to figure out how to navigate those situations to make it so we can have effective care. So that's why it's our belief we don't need this kind of language that then creates more complicated issues where someone could blur the lines of what that looks like.
Well, you just said in your testimony though, but they can do that, but they ethically they cannot discriminate based on selective personal beliefs. But you just said they could.
You have to be able to provide access to services. So if someone's trying to obstruct services somewhere where there aren't very many services based on their own ethical dilemma, then that's not ethical care. They're not providing ethical care. They're not meeting the duty of their profession. So we already have situations where, yeah, we have conscious objection, but then we have a duty. We have to provide referral services. So as the NMA expressed concern about the referral process, that's definitely a concern for us. But I think this bill creates a situation where a provider could impose their personal beliefs on someone and not provide additional access or help to getting additional access. That's our concern.
Okay. And just another question about the Nebraska Nurses Association in particular.
Yeah.
Because I've had some nurses, and we got emails and phone calls about they like this bill. So, is this representative of all nurses, or like, do you guys have do a poll of nurses to see who's in favor of this, or is it more of a board that makes the decision to oppose bills like this?
Yeah, no, that's a really fair question. So the Nebraska Nurses Association is a member organization. We represent our membership. We have a legislative committee. So those of us that testify are on the legislative committee. We follow the standards of our practice with our code of ethics. The American Nurses Association has policy statements. We're a member of the American Nurses Association as the Nebraska Nurses Association. You've heard providers of different beliefs, and we support all beliefs, but we are bound by our duty of code of ethics, and we are, as a profession, we come together and have a standard of care that we then advocate for.
Okay, so more the legislative committee is one who kind of makes the decision on to oppose or support a bill?
Yeah, we have the members of the legislative committee are elected by the members of our organization.
Okay. And they're the ones who make the decision on whether to oppose a bill or not?
Our legislative committee analyzes all the bills of the legislative session and then makes.
Okay, that helps me because now I know how to communicate this to people who are for this, and they're like, why does the Nurses Association come out against this? This helps me communicate this with my constituents too, so I appreciate that clarification.
And we have a legislative day. We hope you guys all come very soon, where we have our members become more active in legislation, because we listen to we have constituents too. They're our members of our organization. So we do get feedback from our members sometimes on what they think. And then we take that all into consideration, all with that overarching code of ethics that we look at and evaluate all the legislation on. Yeah.
Thanks for all you do, by the way. I know you guys are kind of overworked right now with all the nurses, and so I appreciate what you do.
Thank you.
Any other questions? All right, thank you for testifying.
Thank you very much.
Anybody else wishing to testify in opposition to LB? Welcome. You're missing somebody.
Yeah, right. No, she's at daycare this time. Thank God. It was a tough day for me. All right. Good afternoon. My name is Naomi Thompson. That's NYOMITHOMPSON, and I'm representing Ivy Black Girl. We are a reproductive justice organization that centers Black women, femmes, and girls, because when we do, everybody benefits. I am testifying in opposition to LB 810 because patient needs, not personal beliefs, should come first in healthcare decisions. Conscious objection negatively impacts the health of the most vulnerable, perpetuating the racism and discrimination already present in the healthcare system. Allowing conscious objection places burdens on patients and lowers the quality of healthcare. It will create inconsistent care since treatment can become dependent on the values of a given medical practitioner. Limiting the choice of healthcare professionals will be detrimental to any patient, but has even more of an impact on the Black community, low-income folks, and those living in rural areas who already lack the access to healthcare. Being referred to another doctor requiring another appointment will take resources, childcare, transportation, and lost wages for taking yet another day off work. This is a burden for those struggling to care for their families. In particular, this would compound the negative health outcomes experienced in maternal health for Black women and folks with a reproductive system. Black women die from pregnancy-related causes more than 3 times the rate of white women and experience severe maternal morbidity or near-death experiences at the rate 2 times of white women. To achieve optimal Black maternal health outcomes in the state of Nebraska, it is essential to further expand meaningful access to affordable and consistent health care for Black birthing folks, wherever they live throughout their lives. Doctors have a duty to do no harm. This can only happen when patients have access to timely, quality health care that is not dependent on the provider's own personal beliefs. Please consider valuing the health outcomes of Nebraskans and stop LB 810 from moving forward.
Thanks for your testimony. Any questions from the committee? I don't see any. Thanks for coming. We'll take our next testifier in opposition. Welcome.
Good afternoon. My name is Jane Sue, Janeseu, and I'm testifying on behalf of the ACLU of Nebraska. Freedom of religion and association are among one of our most fundamental rights, but that freedom does not give us the right to harm others. This bill would provide an unbridled license to healthcare professionals to discriminate against their patients for almost any reason, refuse to provide them with care, and limit any professional accountability for those acts of discrimination. This measure contains many vague and undefined terms, would be impossible to implement, and would have a chilling effect on the health of all Nebraskans, but most specifically the most vulnerable in their times of need. This license to discriminate will be felt more severely in rural areas where patients already have limited choice of medical providers. Our government should never make it more difficult for individuals to access healthcare. This bill legitimizes unequal treatment or the denial of treatment of patients by healthcare providers, organizations, and insurers. Religious freedom does not mean the right to discriminate. Medical standards, not religious beliefs, should guide and govern medical care. Denying patient healthcare is not liberty. We must do what we can to ensure that all Nebraskans, regardless of background or circumstance, have access to the best possible health care. And with that, we urge the committee to indefinitely postpone this bill, and I'm happy to answer any questions.
Thank you for your testimony. Are there any questions from the committee? Seeing none. Thank you. Take our next testifier in opposition. Welcome.
Good afternoon, Senator Hansen and members of the Health and Human Services Committee. Thank you for listening to testimony today. My name is Abby Swatsworth, ABBISWATSWORTH. I'm the Executive Director of Out Nebraska, a statewide nonpartisan nonprofit working to celebrate and empower lesbian, gay, bisexual, transgender, and queer questioning Nebraskans. Out Nebraska is here today in strong opposition to LB 810. No matter what we look like, where we live, or how we express our genders, we all want the freedom to be ourselves and live healthy lives. This law seeks to enshrine discrimination by healthcare providers and endangers our health, our futures, and denies us the good life. Religious freedom and the right of conscience are deeply held values that we share. But LB 810 is not basic religious freedom. It goes far beyond the careful balance already struck by existing law, which we have heard from other testifiers, and it endangers LGBTQ plus community members among other marginalized communities. The so-called Medical Ethics and Diversity Act would allow any health provider or healthcare organization or any employee therein the ability to deny any specific healthcare service to anyone, which I believe we heard would make it very difficult to operationalize, because how would you know whether someone unloading a truck agrees with the issue or someone providing the actual service? There's a long line of people there to get in alignment to provide a care in a large system. The law is exceedingly broad, which could mean an individual staff member, as I've just described, in a larger hospital or insurance system, could make a refusal of a service already approved by a doctor or an insurance payer. The law would allow employers to deny counseling for someone exploring gender identity, blood transfusions for an individual struggling to recover from COVID, IVF for a family that struggles with infertility, or HIV prevention medications for a sexually active adult. All of this creates patient harm, something that the ethics of healthcare is supposed to protect against. For these reasons, Out Nebraska asks that you not advance LB 810, and I'm happy to answer any questions.
Thank you for your testimony.
Thank you.
Are there any questions from the committee? Senator Getlow.
Thank you. Thank you for being here.
Yes.
You talked about how the law is exceedingly broad, which would mean an individual staff member in a larger hospital or insurance system could make a refusal of service already approved by a doctor or insurance payer. Can you talk a bit more about how the broadness of this, I guess?
Yeah, it doesn't just include doctors and pharmacists, right? It says systems, and that includes all the employees therein, as we understand the bill being written. So it could be someone in the billing department or someone in the department that unloads the trucks that carries the vaccine, as we heard from the medical or the hospital association talking about the difficulty of having the alignment of the whole long group of people, because they're all included under this bill. It isn't clear that it only covers nurses, physicians, and pharmacists.
Okay, thank you.
You're welcome.
Any other questions? Seeing none. Thanks for coming.
Thank you.
Take the next testifier in opposition, please. Welcome.
Thank you. Good afternoon, Chair Hansen, members of the committee. My name is Lacey Bolte, Lacieie Bolte, and I am a representative of Nebraska AIDS Project. Nebraska AIDS Project is a nonprofit organization leading the community to overcome HIV and its stigma through supportive services, advocacy, and education. I'm here today to request your approval of LB 810. At Nebraska AIDS Project, we provide medical case management services to over 1,000 Nebraskans living with HIV throughout the entire state of Nebraska. We also serve parts of Wyoming, Southwest Iowa, and one of the greatest needs of our community is access to safe health care. LB 810 would allow a wide range of medical practitioners to refuse to treat anyone for ethical, moral, or religious beliefs. This also applies to pharmacists who could refuse to provide an already prescribed medication. Based on the broad range of language used in this bill, I'm incredibly fearful that healthcare payers, such as insurance or employers, could refuse to cover life-saving HIV treatment medications. Off script a little bit, HIV medications cost about $3,000 a month. I feel like this bill is sort of incentivizing employers or insurance companies to discriminate against people with HIV for a cost-saving benefit. They don't have to cover this medication because they don't agree with it for whatever reason. They don't have to cover that large out-of-pocket expense. Additionally, practitioners could refuse coverage for LGBTQ+ related care. This includes HIV prevention treatments, HIV antiretroviral treatments, and birth control. Anti-LGBTQ+ bias further enables the spread of HIV. This discourages many in our community from getting tested or treated for HIV for fear of harassment. We know that LGBTQ+ individuals already struggle to access healthcare. A 2014 Kaiser Family Foundation survey of gay and bisexual men in the US found that 15% of them had already received poor treatment from a medical professional as a result of their sexual orientation. HIV continues to disproportionately impact certain populations, particularly racial and ethnic minorities, gay, bisexual, and other men who have sex with men, and transgender women. In 2020, 68% of all new HIV diagnoses in the United States were among gay and bisexual men. We know that people living with HIV who have access to medical care and treatment can live long and healthy lives. LB 810 is unsafe, unethical, and a dangerous precedent to set in the medical field, and I urge you to oppose LB 810. Thank you for your consideration, and I would take any questions.
Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thank you for your testimony. This is an angle I had not considered, so I appreciate you testifying about it. And now I'm looking at page 6 of the bill, lines 15 through 18, and it says a decision to decline to participate in or pay for healthcare services on the basis of conscience. And I'm seeing now, is that kind of the area where you're extrapolating this from?
Yes, I'm very concerned that employers or insurance companies will discriminate against people living with HIV under using this bill, but perhaps maybe it's a financial incentive because the medications are so expensive. I also think about hepatitis, very related similarly, costs thousands of dollars for treatment. So there's a financial incentive to discriminate here.
Okay, thank you.
You're welcome.
Any other questions from the committee? Seeing none, thank you.
Thank you.
Let's take our next testifier in opposition. Welcome.
Hello. Chairperson Hansen and members of the Health and Human Services Committee. My name is Sarah Marish, Sarahmaresh, and I'm the Healthcare Access Program Director at Nebraska Appleseed, testifying in opposition to LB 810 on behalf of Appleseed. We're a nonprofit legal advocacy organization that fights for justice and opportunity for all Nebraskans, and one of our key priorities is ensuring that all Nebraskans have access to quality, affordable health care. And a key component of that is also ensuring there's equitable access to healthcare. Because this bill effectively restricts healthcare access to services and disproportionately impacts communities that have been marginalized, Nebraska Appleseed opposes this bill. This bill, as you heard, is harmfully broad. It very vaguely defines what types of services can be denied, and it provides that medical services means medical research or care provided to any patient at any time over the entire course of treatment, and then goes on to list wide-ranging, non-exclusive examples. What will this look like in practice is hard to consider. It's difficult to imagine a service that could not be permissibly refused under this bill. And as you've heard from testifiers before me, this bill applies more broadly than providers. It also applies to entire institutions and even payers and insurers who could broadly deny paying for types of services. And not only is this bill overly broad, it also has negative impacts on Nebraskans and their health. Communities that have been continuously marginalized, including those with low incomes, people of color, and members of the LGBTQ+ community, already disproportionately face barriers to healthcare access for a myriad of reasons. This bill will effectively create more barriers to further exacerbate deep health disparities and inequities. When providers can deny any nearly type of care based on their broadly defined conscience, Nebraskans will have to scramble and expend extra time, money, and resources to find appropriate care. And that's if Nebraskans are even aware that they are being denied care options based on their providers' beliefs. LB 810 also lacks guardrails to protect patients. There aren't any requirements to inform patients their care is being limited by their provider's personal beliefs, and it certainly isn't required in advance of the treatment or relationship development. Data shows that patients are often unaware of limits on care, and providers often feel like they do not have to disclose their limits on care to patients in these contexts. This bill could also have a chilling effect on patient-provider relationships and prevent disclosure of information to their providers, and that would also harm the administrator of healthcare and harm outcomes for Nebraskans. And finally, as you've heard a little bit more about today, LB 810 isn't needed. You've heard from medical professionals that this is already operating in practice in some ways, but healthcare providers and entities already have protections under current law. Federal laws permit providers to refuse certain healthcare services on religious and moral grounds, and Nebraska's own state laws protect separately for entities as well. Nebraska Appleseed is committed to ensuring all Nebraskans have equitable access to healthcare services and therefore opposes this bill. Thank you and happy to answer any questions.
Thank you for your testimony. Are there any questions from the committee? Senator Ballard.
Thank you, Chair. Thank you, Chair. And excuse me. Can you unpack the federal law? I know previous testifier talked about Title VII. Can you unpack that a little more for us?
Yeah, so I guess I'm more specifically can talk about the abortion. There's some laws that permit individual. I think Senator Kavanaugh referred to it earlier. I think one's called the Church Amendments. Is just the name of the bill that permitted folks to deny abortion care under federal law. And there's also a couple of other federal laws that permit entities to have flexibility in that way for abortion, since that came up frequently as well. And then the state law component as well, there is a separate protection for entities as well.
Yeah, thank you.
I might have one question.
Yeah.
Because maybe piggybacking off what he mentioned, Senator Ballard.
Yeah.
So if this bill passes, so is there already federal law in place to prevent a doctor from providing care to somebody based on sexual orientation?
So, I mean, there are like broad protections under federal law, anti-discriminatory practices. Yeah. So there's, I think, some constitutional claims where, you can't have discrimination on the basis of sex and things like that.
And that would supersede anything in this bill then, right? So I see where you're coming
Yes.
from, but I don't think in that aspect, nothing would change with this bill passed, legally anyway, right?
Sure. Well, I think yes, that's a fair question and fair point. I think more broadly speaking, though, a really broad bill like this can have the impact still of encouraging disproportionate and discriminatory practices. And so even, if it would be superseded by federal law, the remedy would be the person would have to go sue them, right? And then the court would determine down the line that, yes, you shouldn't have been denied that care on the basis of your sexual orientation. And so, in a court, yes, that's the practice. But in reality, we're concerned that a bill like this would encourage providers, encourage other entities to have that sort of discriminatory practices in practice.
Okay, that's what I was kind of wondering. So your concern is it might encourage them to do it. It's still illegal either way, but this might just embolden them to behave or act a certain way that's still illegal, but it might make them do it more often.
Yes.
Something like this passed. Okay,
Yes.
all right. Okay, thank you. Senator Kavanaugh.
Thank you. That spurred a question for me. So if we were to pass this, then we wouldn't be compliant with that federal non-discrimination law. Would we potentially risk losing federal funding for Medicaid and Medicare?
Yeah, I think that's a really good question, Senator Kavanaugh. I don't have a great answer for you right now, but I do know, I think the fiscal note provided with this bill, the Department of Health and Human Services provided some information about how it would interact with federal law and state law. And I think maybe express some concerns about federal law and how that would interact. But
thank you. I have it here. I should have referenced that myself. Thank you.
Any other questions? Seeing none, thank you.
Great, thank you so much.
We'll take our next testifier in opposition to LB 810. Welcome.
Hi, good afternoon. It is warm in here. You guys are holding up well. Thank you all for the time to testify this afternoon. My name is Marielle Harding, Marielle Harding. I am the Senior Director of Programs and Initiatives at Nebraska Family Planning, and I'm here to express opposition to LB 810 on behalf of Nebraska Family Planning and our board. Nebraska Family Planning is a nonprofit organization, and we work with agencies across the state to improve access, quality, and equity to family planning services. The services that we provide across the state are provided at no cost or on a sliding fee scale. Our clinics do accept insurance as well. In 2021, our network served over 20,000 individuals, with over 60% having incomes below 100% of the poverty line. We are opposing this bill because it could allow any medical or health professional to refuse to treat any patient and any payer to refuse to pay for services or medications based on any ethical, moral, or religious reason. While the impacts across the healthcare system could be grave, as you've heard, impacts to sexual and reproductive health are likely to be particularly marked. As context, I'd like to share a few statistics about sexual and reproductive health with you for the state of Nebraska. Gonorrhea has increased from about 3,000 cases in 2019 to about 3,500 cases in 2020. That is a trend that is continuing year over year of an increase. Syphilis has increased rapidly over the past several years, rising from 70 cases in 2017 to 255 cases in 2021. And in 2021, the highest number of new HIV diagnoses was reported since 2010 at 107 cases. And this trend was particularly marked among rural, non-Hispanic white men. All of those statistics come from Nebraska DHHS or from the CDC. So what these statistics demonstrate is that there are already barriers in place to accessing quality sexual reproductive health care. Some of those are provider availability, cost, stigma, and this bill could exacerbate all of those barriers. We've heard a lot about the perspectives of providers, and I'd like to invite you to think about the experience of a patient. So given the shortage of providers in our state, and just to be specific, every county outside of Douglas and Lancaster County report a shortage of at least one type of primary care specialty. So in those counties, let's imagine an individual seeks services for treatment for a sexually transmitted infection and is denied care to the ethical, moral, or religious leanings of any member of staff at the clinic that they seek that care. What will happen to that individual? Will another staff member follow up? It does not appear to be required in the bill. Will they receive a referral to another clinic? We've heard that's not required in the bill. And then how far will they have to drive to receive that care? Will they have to take off work? Will they have to find childcare? And in this context, how many people will find that too burdensome to follow through? I think these are really important questions to think about within our state as we think about the rural nature of our state and the health disparities that already exist. This bill will perpetuate and exacerbate the existing health disparities and reduce care for Nebraskans statewide. We've also heard about the challenges of continuity of care, and without those stipulations, or even with them, continuity of care is very difficult. This bill would also reinforce stigma and discrimination. Even if a patient is not blocked from services, it could discourage people from seeking treatment and cause stigma around these necessary healthcare services. We believe that one's ethical, religious, or moral liberty should not be on a crash course with another's access to healthcare. These broad exemptions will cause harm to patients, and we at NEFP stand in support of our fellow Nebraskans' right to equitable, quality, and accessible care and in opposition to this harmful bill. Thank you for your time.
Thank you for your testimony. Are there any questions from the committee? Seeing none, thank you.
Thank you.
Take the next testifier in opposition, please. Good afternoon.
Hi. My name is Judy King, Judyking, and I'm an opponent of this bill. Oh, is my light going? Okay. I've been at all these bills, these national right to life bills, abortion bills, bills against LGBTQ people, everything like that, along with Tom and Karen Bowling, Benzer. And it's the Catholic Church just pushing ahead with more bills, or the religious right pushing more bills to stop the care of LGBTQ people and women. And I had my daughter, who's over 30 now, at the Catholic Hospital, CHI, and I had just absolutely wonderful care there. It was just wonderful. And but nowadays, knowing if you're going to tell doctors how they can treat and how they can't treat, allow them to do whatever they want, I would never go to CHI again. And I used to work at the NMA, and the doctors need to have they've been hit by insurance companies telling them what to do. They should have the freedom to practice as they want. They don't need your bill to tell them that they can or can't do things. They should do what the doctors decide to do, or what the medical society decides to do. And I think Mike Mancuso, I think, is here. He's on the board of the NFA. And I think we need to boycott him. He works at a bank. And let's see, Karen Bowling is on the board of directors with the NFA, and that's a national hate group. So that's all I have to say. It's just another bill against women. That's all it is. Anybody that has LGBTQ or women in it, those people are here to.
Okay, so see if there's any questions real quick, just
No.
make sure. Any questions on the committee? All right. Might surprise you sometime, you know.
No, I'll never.
Take the next testifier in opposition, please. Welcome.
Thank you. Good afternoon, Chairman Hansen and members of the committee. My name is Hannah Robleski, HANNAH WROBLEWSKI. And I am here in opposition to LB 810 and to read part of a statement from the American Atheist. I'm not going to read the whole thing. A lot of it has already been covered today, and I gave you all a copy. But I am here because LB 810 allows the CEOs and boards of hospitals and insurance companies to place their religious beliefs above the health and safety of patients by allowing them to refuse to provide necessary medical care. There's simply no evidence that healthcare workers are regularly forced to provide health services that violate their religious beliefs. In fact, the opposite is true. Hospitals and other healthcare institutions regularly accommodate the desire of workers to avoid certain procedures that do not align with their religious beliefs, as we've heard in testimony today from them. Although this addresses a non-existent problem, LB 810 will have a very real cost in terms of harm to Nebraska patients, particularly for women and LGBTQ people, and people living with HIV, people living in rural areas who may not have another doctor or pharmacy to go to. This will allow any provider, institution, or payer to refuse to provide any healthcare service and then justify this denial with religious or philosophical belief. A couple examples: counselors could refuse to care for a young LGBTQ person in crisis and then refuse to even provide a referral. Pharmacists could refuse to fill prescriptions for Viagra, PrEP, HIV medication, or birth control. Although the proponents claim that LB 810 is about religious freedom and consciousnesses of individual healthcare workers, this bill is actually about denying care to anyone that seeks medical care for which they disagree, especially women and LGBTQ people. LB 810 lacks basic measures to ensure the safety of patients is not affected by a healthcare provider, institutions, or payers' religious refusal. There's no obligation to inform the patient that their health is being subject to religious ideology rather than medical best practices, or that certain services will not be provided even if medically warranted. There's no obligation to refer patients to other providers for relevant services. This bill, simply framed, will endanger countless lives in Nebraska under the guise of religious freedom. We urge you to reject this remarkably dangerous legislation. Please do not put the interests of a few outlier religious healthcare institutions above the health and safety of Nebraskans. Thank you so much.
Thank you for coming to testify. Any questions from the committee?
Thank you.
I have one question.
Yes.
Maybe a comment. I don't really know for sure because I'm not 100% certain. But this is what I should ask one of the lawyers before. Is a hospital, I think they cannot ask your religious affiliation, can they?
I'm not a lawyer, so I don't know
I'm
for
not
sure either.
So I just didn't want to say something without being 100% sure. So I sometimes put it out there and then somebody usually responds to us when we're done with the hearing. So, okay, just a question about that. That's all. All right.
Okay.
Thank you very much.
Thank
Appreciate
you.
it. Anyone else wishing to testify in opposition? And, oh, yep, we got one more.
You may as well just have it in Caleb's.
Hey, Senators, members of the committee. I'm Penelope Harding, PENELOPEHARDING. I'm not representing an organization, I'm representing myself. I wanted to give some insight on what it was like for somebody who was in a similar situation to many others that would be affected by a bill such as this. So I am a queer woman living in Nebraska, originally from very rural Nebraska. I had several troubles with my mental health growing up with an attempt on my life, both on when I was 15 years old and again when I was 18 years old. My doctor had provided all the care that they could think to give me, giving me a therapist to go to, referring me to a hospital that I could check into to stay in overnight, to try to see what was going on, like why I kept having these tendencies over and over again. And through all the introspection and through all the therapy that I did go through, I had realized that I was a transgender woman. And it's something that came very out of left field, but I knew that once I had gotten there that I had figured out that's what the issue was. And sure enough, the past 2 years since I figured it out have been the best years of my life. When I originally went to go get gender affirming care in the way of hormone therapy, I had gone to my doctor saying, the doctor that I had gone through with my past 2 attempts of my life, who was with me through that, and told her the situation and how gender affirming care would help me. And she stated how, in her time before this was seen as a mental illness, that she had asked what my religious affiliation was, what my relationship with God was like specifically. She had asked what my family situation was like. She had promised, upon much goading from me, that she would seek out help for me in terms of finding other doctors that would be able to provide this care for me. She beat around the bush a lot. I never heard back. I see my time is up.
You can wrap up your final thoughts.
Okay.
I think you're our last opposition, so.
Okay.
So give it a minute.
She was a huge contributor to churches in Nebraska, and specifically the Catholic Church over in David City. And, I know that's where part of it was coming from, where if a bill like this were to be in place, that would be them saying that it doesn't go with their conscience or their religious code, would be a guise for the discrimination that they're placing against queer people in Nebraska.
Okay, thank you for your testimony. Any questions from the committee at all? Seeing none. Thanks for coming to testify.
Thank you.
We'll take the next opposition testimony.
I had to make copies this time. My Eagle Scout Be Prepared is shaming on me. Hello, my name is Eliana C.B. Wallace, ELIANASIEVE-WALLES. Please refer to me with they, them pronouns. I am from District 49. I come to you representing myself. As a Christian, I understand the notion of protecting conscience. However, the implications of this particular bill deeply worry me, particularly regarding contraception and gender affirming care. As you saw on Wednesday, people very clearly are interested in protecting gender affirming care. Even if you don't advance LB 574, this bill would fundamentally circumvent that opposition to this bill and therefore make it harder on an already burdened population to receive healthcare. However, I'm also deeply concerned about contraception. I have a condition called PCOS. In order to treat the symptoms of this condition, I use birth control. While my dating life may be dry, this is a fundamental medication to help me manage these symptoms of my condition. Without it, my condition is debilitating. I have memories of staring at my painkiller bottle and being unable to stand because I was in so much pain, I couldn't grab it. Fundamentally, I have a system to get my medication that works with my insurance. Under this bill, though, my doctor could then potentially deny me my prescription and put me back at square one, even with a referral. It could end up becoming a significant financial, time-intensive, and energy-intensive burden on my family. I come from a legacy of fear. My parents are LGBTQ, and I remember hearing stories of them worrying about being denied care because they were gay. While the proponents of this bill claim that no patient can be turned away because of who they are, I don't want anyone to experience that type of fear that they won't receive care, especially in a medical context where people's lives could be at stake. I ask you to oppose LB 810 because I believe the implications of this legislation will do far more harm than they will good. Thank you.
Thank you for your testimony. Are there any questions from the committee? Don't see any. Thanks for coming. Anyone else wishing to testify in opposition? All right, seeing none, is there anybody who wishes to testify in neutral capacity?
Good morning, Chairman Hanson and members of the Health and Human Service Committee. My name is Bo Botelho, B-O-B-O-T-E-L-H-O. I'm General Counsel for the Department of Health and Human Services. I'm here today to testify in neutral capacity for LB 810. The department has been working with Senator Merman and the Nebraska Attorney General's office about some concerns with the bill as drafted. We want to thank the Senator for entertaining our concerns and working with us to draft an amendment to resolve these issues. For your reference, the concerns we have had with the green copy of the bill are as follows. DHHS had concerns that LB 810 as introduced would have conflicted with existing statutes created to support the health, safety, and protection of the public. Specifically, it will require DHHS to provide a medical practitioner with any complaints that it has received that may result in revocation of the medical practitioner's license, certification, or registration within 14 days after receipt of the complaint. DHHS does not make the decision to pursue discipline that may result in revocation of a license under the UCA. The Attorney General has the authority to initiate a petition for discipline and makes the decision to pursue revocation or a lesser sanction. When DHHS receives a complaint, there is no way to know with certainty if the complaint may result in revocation of the license at that time. DHHS has first to determine if the agency has the authority to investigate the complaint. If an investigation is undertaken, this is done in consultation with the Attorney General and ultimately the Professional Board of Jurisdiction. The process will inevitably exceed the 14-day reporting period. The notification requirement LB 810 could also have discouraged members of the public from filing complaints against practitioners out of fear of retaliation. The confidential aspect of an alleged victim's reporting best serves the patient and the overall public interest. LB 810 would have posed other problems for the healthcare patients and the department. The $500 per day penalty that may be imposed in an LB 810 would have exposed HHS and the state of Nebraska to significant financial liability. Further, the department would be exposed to civil litigation since the bill provides for injunctive and reinstatement relief, as well as monetary damages by the healthcare professionals and institutions and any party aggrieved by a violation of the act. This would greatly impair the Attorney General and DHS's ability to bring these cases forward. Again, we worked with the Senator on an amendment that would resolve these concerns. I thank Senator Merman. I thank you for your time and the opportunity to testify today. Happy to answer any questions.
Thank you. Are there any questions from the committee? All right, thank you. Anybody else wishing to testify in neutral capacity? All right, seeing none, we will welcome up Senator Berman to close. But before he does, we did, for the record, have 114 letters in opposition to 810 and 126 letters in support of 810.
Okay, thank you very much. Really appreciate everybody sticking around this long. I didn't think the hearing would go quite this long, but there's very a lot of interest, and I can tell by you guys' questions that you have very thoughtful questions, and I really appreciate that. And I think it was worth all that extra time. I do have a long list of answers to a lot of the situations that were brought up, but I know we're short of time, so I won't
Just
go
fit it
through
into
all
3
that.
minutes if you can.
Okay.
I'm just joking.
It's good for patients also, this bill, because patients can more easily select a provider that fits their values. So I think that's very important. And another important thing, and we talked about quite a bit, we want to increase the pool of medical professionals. And I think this bill will increase the pool. A big effect that it could have is right now, medical providers or students are kept out of medical school because of their deeply held religious and conscientious beliefs, and especially certain fields of medical care. So just an example of that, there's a pro-life OBGYN in a state south of here, and she has just a huge waiting list of women, that want to access her care. And, we hear about this as limiting access of care to women, but actually it would very likely increase care to women. And also, we heard a lot about cost being a factor. Cost is not a factor at all in this legislation. There's never been a civil lawsuit because of cost, and that's not even part of this bill. Also, you can't discriminate because of who the person is at all. It's all medical procedures that you can provide or not provide with this bill. So I think I've covered most of what I wanted to answer, so be open to any more questions if anybody has any.
Thank you. Are there any questions from the committee? Senator Kavanaugh.
Sorry, I didn't mean to hit the microphone there. Yes, I do have questions. I want to get to that cost question, but before that, I wanted to ask if the standard of care conflicts, I wrote this down because I didn't want to misstate it. If the standard of care conflicts with moral, ethical, or seriously held religious beliefs under this bill, is a provider is not held to providing that care. So if the standard of care is to provide emergency contraception, under this, they don't have to do that, correct? Because of their religious beliefs.
Correct.
Okay.
Emergency contraception they wouldn't have to provide, correct?
And if they didn't agree with emergency contraception, not because of religious beliefs, but because of moral or ethical beliefs, something different than religious beliefs, that still would apply.
I'll repeat that one more
So
time.
if a physician was an atheist, so it wasn't because they were a Christian or something like that they didn't want to provide emergency contraception, but they didn't believe in emergency contraception as the standard of care for a victim of rape that comes to the emergency room, because that's a moral belief of theirs, then under this, they would not be obligated to provide that care, correct?
Correct, if that's a deeply held conscientious belief, yes.
Okay, so if LB 626 were passed into law and our medical providers disagreed with the new standard of care that LB 626, that's the abortion ban, were to establish, then if we also enacted this into law, they would not be obligated by the state to abide by LB 626. Yes.
Well, the individual
Providers.
caregiver would not be correct.
Okay. Thank you for that. My other question under this is on page, do you have a copy of your bill?
Yes.
Okay, on page 6, lines 15 to 18, that's where the Nebraska AIDS Project came and testified. And that's where they were talking about the cost and the discrimination based on if you didn't want to provide gender affirming care, or not even gender affirming care, just expensive medications for, their example was AIDS patients. The way that I read it is that it would allow a payer to deny those claims. And you said that that wasn't the case. So I'm giving you the chance to say, perhaps that wasn't your intention in this legislation. Is that something that you would be willing to work on additionally?
The way I understand it, and I think this would be right, I'm not a lawyer, but if the payer had that state in their moral or their, I don't know what their statement of belief, I think there's a better term for
A
it.
mission
but-
statement or
Yeah,
value
mission statement. That's what I was trying to think
Yeah.
of. Thank you. If they did have that in the mission statement, I think that would be true. But as far as I know, no insurance company has that.
So this, right, they don't. But this is very broadly written, and I understand some of the reasoning behind the broad language. The concern that was expressed, and I would say it's a concern that I also have, is that it is so broadly written that even though they don't have that as a mission statement or a value statement currently, they could say that they would refuse to pay for this because of their mission or their values.
Well, I don't think that's true unless they had it in their mission statement.
Okay, perhaps we can talk further about how we can tighten this language to be more clear.
Sure, always open to suggestions, but yeah, I think they would have to have it in their mission statement to
Okay.
do that.
I have another question, but I'll.
Like, sure, are there any other questions just to see? All right.
Okay.
Yep.
I think this is my last question, but no, I'm sorry, I have more than one question, but what is the mechanism to prohibit abuse for this? So like you just said, if it's not in their mission statement, they wouldn't be allowed to do that. So if an insurance company, in this specific example, if an insurance company does not have this in their mission value statement and they deny treatment, claiming that it goes against their values, what is the mechanism for enforcing abuse of this?
Well, the insurance company would have to have it in their mission statement.
But if they don't, and they just go ahead and deny a patient's claim for payment, and they just say, well, it's because of this legislation that we denied it. What is the mechanism in which there's recourse either for the medical community to recoup those dollars or the patient to recoup those dollars?
I think there would be civil action could happen, or I don't know if there's other methods of disciplining insurance companies, but
What-
that could
I'm
happen.
just using the insurance company as the example. I mean, if there's abuse in this, I guess if it's a doctor that's abusing it, what is the mechanism for? Does it go to the Board of Health? Do they lose their license?
Well, I assume it would go the same way as any complaint against a doctor is handled to the
They're
Board
handled.
of Physicians. I don't know what the term
They're
is. Board
handled
of
different
Physicians.
ways, and I'm sorry, I am not as familiar with all of the language in this particular bill, but I didn't see, we see mechanisms in other legislation around medical care that, and again, this is a potential for an amendment, but I don't see a mechanism that says that it goes to the Board of Health for review or anything like that, and that is more clearly stated.
Yeah, I
in the
think that's just a given since it's not talked about in the bill.
Okay. I forgot I know what my last question was. Okay, I swear this is the last one. I know, this is like, it's 1:40. Okay, on page 6 at the top, well, one word is on page 5, upon, but upon patient request, the medical practitioner shall assist in the transfer of the patient's care. So I think this is part of where the NMA had their opposition, is that this is too broad. But I would say that this sort of ties into one of our previous testifiers, Penelope Harden, who said that they had asked for those referrals and weren't giving them. So in Penelope's case, when she asked for that referral, this would require that they had to do that referral.
Yes, we've been working with the NMA to have a clearer, I guess, a better mechanism or a different mechanism of referral.
Sure.
And we weren't able to come to an agreement with that. But
Okay.
what was your question then about the
Well, and specifically in the patient's case, and our testifier had spoken about how she had tried to get her doctor to give her referrals for appropriate care, and in her words, that was slow walked, and she never got the referrals that she was seeking. This would require the doctor, if a patient said, I would like a referral for appropriate care, it would require the doctor to give them that referral.
Yes, we did address referral in the
Okay.
bill, and of
So
course,
then if LB 574, which was the bill we had earlier this week on gender affirming care, if that were to not pass and a patient asked for gender affirming care, their doctor would be required, whether they agreed with the care or not, they would be required.
well, the doctor would be required to give information on the referral. That's the referral that the eighth amendment we're working on. Some kind of information on referral.
Okay, but you have not come to an agreement with the NMA on what that referral process would look
No,
like?
it wouldn't be definitely to another doctor that would be different than the religious beliefs of the referring doctor.
Okay, thank you.
Any other questions from the committee? I didn't have one, but I have one now.
Yeah, no, go ahead.
Thanks to Senator Kavanaugh. We tend to do this. She brought up 626, the heartbeat bill.
Yeah.
And so then if your bill passes, this would allow them to, if I'm hearing that right, then to supersede the heartbeat bill. But I think your bill would not allow somebody to supersede something that's law, correct?
Correct.
Yeah, so
They would only, a doctor, a medical provider would not be forced to provide a procedure that they disagree with.
Because I think we're talking about conscientious objection.
Yeah.
And that's typically passive. Like it's something you're just being prevented from forcing to do something, not being able to, break the law because you have a moral or conscious objection.
Right.
Okay.
Just like right now, you wouldn't expect an orthopedic doctor to perform an abortion for the similar type thing. But, this is because of right of conscience, not.
Yeah, this mainly prevents you from being forced to do something.
Yeah.
From my understanding.
Yeah.
Okay, I just want to make sure I clear that up. So, any other questions from the committee?
No forcing of procedures, only refusing to do a procedure that is against your religious and conscientious belief.
Good. All right. Well, seeing no more questions, thank you.
Thanks a lot.
That'll close the hearing for LB 810. And we are actually going to take a short little break so we can get something to eat real quick. Since we were supposed to take a lunch break at noon. So we are going to come back at 1. We're going to come back at 2:15, actually.
Because my computer crashed. My computer crashed.
Okay. Well, she had a bill, and then I got mine's first one up, and I think we need that.
All right. It's like this one. It's right by.